Good morning, everybody, and welcome to Quality and Patient Safety Day, Quality Improvement and Patient Safety Day. This is something that we look forward to with great anticipation, a small degree of dread every year because of all of the behind-the-scenes stuff. And I just want to start out by thanking Tammy Elliott for all that she has done she's in the back there, she's holding down the fort. Tammy really is ultimately responsible for everything that happens here, which means it's going to be great. I'm very, very pleased also to be here. My name is Jeffrey Bennett. I'm the CLEAR director for UT College of Medicine here at Chattanooga. And this is our 12th QIPS Day here at Erlanger. Since we're letting people sort of trickle in a little bit, I'm hoping that now that we're saving daylight, people aren't confused about what time of day it is, and we might have a big rush in about 30, 45 minutes. Anyway, before we get going with our official program, Dean Haynes is with us today, and he'd like to have a few comments, so I'll welcome him to the podium.
Thanks, Jeff. Good morning, everyone. First of all, thanks for being here. I want to highlight just a few people in the room. Obviously, we have administrators, we have nurses, doctors, techs, but specifically, I want to highlight Tom Angston in the back, who is a retired engineer, now patient care tech, works in the ED, but worked his whole life on the engineering side in the quality realm. And so really thankful he's here and really appreciate your engagement with Dr. Campbell and Dr. Bennett as we try to figure out how to use quality to obviously improve patient care, but outcomes and value, right? Because everybody outside the building is looking for value as the cost of healthcare skyrockets. So Tom, thanks for being here and taking your time. Also want to highlight the faculty in the room. I think it's really important to highlight those who are here taking time out of their patient care responsibilities to be here. And Dr. Henry Okafor from urology, Dr. Anand Shridarani from urology as well, Dr. Arish Manyam, and then Dr. Monica Jones, who's in the back, administrator from East. And then there's many faces in the room I don't know, but we're looking forward to a great day. Want to highlight Dr. Adam Campbell, Dr. Jeff Bennett, and then Dr. Paul Schwartzberg as the primary drivers of putting this together along with Tammy Elliott. So hope we all learn today how to improve value for our patients and improve care. And we'll thank John in the back who's helping us with the IT and AV. So with that said, I'll turn it back over to you, Dr. Bennett.
All right. You're so much better at that than I am. I appreciate you. All right, let's see. Now, Tammy, what do I do next? Get off this slide. Yeah, I've done this before. It is not moving. Okay, I can escape. All right, friends. Here we go. Well, as we get started, as I said, this is the 12th time we've gathered to celebrate quality improvement, patient safety efforts here at Erlanger. This was spearheaded back in 2012 when ACGME rolled out a new program called CLEAR, or the Clinical Learning Environment Review. And this concept was intended to embed certain characteristics and principles within learning programs, as residents were found not to be very engaged in the operational factors within their sponsoring institutions. That is ACGME speak for hospitals. So the sponsoring institutions and ACGME were asked to partner to create learning environments that helped learners gain skill sets which were essential, increasingly essential in our marketplace, but also to help further the efforts of hospitals to improve and seek excellence. So that was the big concept. And now we've gathered for the dozenth time to look at some of the work products of that effort. Now, CLEAR rolled out a recipe for success that involved 6 domains, 6 areas of focus. And they included supervision, teaming, safety, quality, professionalism, and well-being. Now, this is a vast oversimplification for the idea. Each of these domains has multiple pathways, which has multiple levels of effort. And this program has more or less been intact since, as I said, 2012, with some modifications around 2018 when they updated the process somewhat. Now, everything ACGME proposes, they also tend to want to inspect. So they come out on their own. This is different than your program site visits. This is a institutional visit that happens every couple of years. And we've had some opportunity to learn from those things and digest what the report shows. And at a national level, the product has not really been found to be all that appealing. At the end of the day, as the site visitors walk through institutions, including our own, and they talk with learners, they talk with faculty, they talk with staff members, they realize that there's been relatively weak uptake of these concepts and relatively low engagement of learners and their faculty in the constructs of their organizational efforts to improve and to basically focus on what patients need and expect of us. So looking through this, one of the take-home lessons is the emphasis on learners. The notion that this was rolled out with a focus of creating effective learners maybe skipped a few important steps in that their faculty really had not been deeply immersed in this either. And so there really hasn't been, in most organizations, an opportunity to develop the people who develop the learners. And that's a big next phase for improvement. Second of all, in many of these organizations, they were struggling themselves with respect to those characteristics, those principles. And learners maybe find themselves in spaces where some of these things, professionalism, teaming, supervision, aren't particularly robust. In many of our institutions over the last decade or so, we found ourselves struggling with meeting patient requirements on an everyday basis, and it feels a bit like a firefight. And so the clinical learning environment, the clinic, the operating room, the ward, maybe feel like they're trying to catch up. And how are they going to engage forward-thinking, long-term planning kinds of ideas on their own? Oh, and by the way, and involve their residents and fellows. So there's been a bit of a reset here at Erlanger and elsewhere, and it looks a bit like this. So if we think about ACGME goals, and we're talking about milestones, we think of that as a journey that occurs over an entire training window, 3, 4, 5, or more years. And we're very comfortable with that notion that, you know, as long as the learner gets from A to B over that training window, we've done well. But if we frame shift that to what a customer or patient needs and wants to see when they come to our clinic or come to our ward, we realize that a lot of those characteristics need to already be there. And that the mindset isn't so much on developing those learners over a 3 or 4 or 5 year window. It's about developing the whole system to be in that space where patients arrive and they see the product, they see the benefit of that work. So here's the plan. We have embedded departmental leaders across our organization within departments as our leads for quality. And we think with the proper motivation, we're going to see a vast improvement in how things turn out. That was a joke. I tell you what, I got to work on my punchlines. Now, what we realized is that in order to get any further, we're going to have to put a lot of work into developing faculty members who trainees look to for guidance and support. And across the organization, we have incredible talent, incredible interest, really, really good people. And we think that if we can engage with them in new and better ways, it's going to yield better results. So over the future, we anticipate there's going to be a gradual transition from a very centralized and very resident fellow focused model to really looking at the faculty, supporting them, and helping them develop their internal systems such that learners are experiencing these things on a more routine and robust basis. So this recipe required a little butter, so you always got to put the pictures of the bosses up on a slide. So quality leads for the organization, Dr. Adam Campbell, who's my partner in putting this together, Dr. Paul Schwartzberg, our DIO, they're basically quality leads for our organizations. They're responsible for whether we're basically winning. You know, are we getting ahead? Are we making the progress we hope to make? And those that they look to for leadership are seeking out better alignment. One of the first things that Dr. Haynes told me as we were starting to work together on CLEAR, was that he really wanted to see that what we do matters to the hospital. That we have to be working in alignment with our sponsoring institution and leaning into the priorities and goals of that institution. And that was going to be essential to our progress going forward. And Mr. Coleman, of course, has been a very, very strong partner in thinking about how we're going to leverage all of our talent to make a better tomorrow. And some of the things that have emerged recently is basically a better sense of alignment. That compassionately caring for people and creating healthy Tennesseans and thriving communities, that's a shared purpose. These are completely overlapping ideas. And that they lean heavily on the notion that quality and patient safety are essential. There isn't really another path. In thinking about clinical learning environments, they're all over our institutions. This doesn't include our FQHC. It doesn't include our other partnerships where patients are being seen and cared for, and we may or may not have residents or fellows in some of these places, but they're still considered clinical learning environments. And that they still require the same types of programs and supports, whether residents or fellows are there or not. Leaning into the need for professionalism and teaming and supervision to make sure that we're doing the right thing, the best thing, and we're doing it consistently as partners. And the notion that as we do these things, we all benefit. Because the effort brings us together, and it doesn't make it a doctor thing or a resident thing or a fellow thing. It makes it an all of us thing. So everyone who is in that clinical learning environment, that clinic, that operating area, that unit, is partnered in setting goals and achieving them, utilizing a structured model that is supported and encouraged and celebrated. So as we look forward, it's really going to be with a slightly different point of view. It isn't in any way changing our emphasis of needing to deploy these mindsets and capabilities to our residents and fellows. But it's understanding that that's going to be done because we're doing those things with everyone else too. So to explain to us how that's going to play out, I'm going to invite my partner in crime, Dr. Campbell, to the podium. And don't forget your chef's hat, sir. All right. So he's the head chef and leading the effort here at Erlanger, and he's going to help share with us some of those structures and how that partnership works.
All right. Thank you, Dr. Bennett. I can put this on for a photo opportunity, but it really is an honor to be with you this morning. And this is a nice crowd. It's good to see everyone. Like Dr. Bennett said, this is, I think, the epitome of collaboration. When we talk about quality, we talk about safety, and ultimately, we talk about the patient experience. How do we create value, like Dr. Haynes said, all within the paradigm of teaching and learning? It's a complex system. So what we do as a hospital system, as a healthcare system, working with the college, is setting foundations, setting philosophical foundations, setting standardized method foundations to make all this happen. The GME does that, and our accrediting bodies and internally our QI methods at the hospital system do this as well, setting foundations for how we move forward. The system as a whole, we like to fashion ourselves as a learning system. So if we have safety events, if we have opportunities for improvement, we have to learn from those. Okay, we have to have standardized ways in which we learn. Of course, we have to do that on the academic side, but we also have to do that on the quality side. So you see the synergy in how this would work. In order to put all that together, we have to have a culture that drives this. The ACGME, through the clear visits and through teaming and other mechanisms, really focuses on culture. I posit that if you have a good safety culture in an organization, you're going to have a good overall culture in an organization. They go together hand in hand. And that, of course, all drives quality. A few other things on the quality and safety culture side is you have to have accountability. Dr. Bennett showed some faces up there, and I would diminish the role of the administrators and really pump up the role of the faculty and the quality leads within the different programs. Very, very important. And we say accountability, and it almost gives a like an overbearing feeling to it, but it's more, it should be a collaborative feeling around how do we drive accountability all together. The second part I think is very important in culture is psychological safety. We have to be willing to openly discuss things that need to be improved. Okay. When we're dealing with patients, we're dealing with families, we're dealing with each other. All right. Sometimes it's a very hard thing to do. So if we have that culture in place, the learning system will be a byproduct of that. We'll reliably and transparently learn as a system and improve. So healthcare in general likes to steal from other industries. Okay. Naval aviation, commercial aviation, nuclear power, a lot of these industries have been at this a little bit longer than healthcare. These industries are known as high reliability organizations. These are industries that have a high degree of standardization. They bake out errors, okay, from their systems, which is a very hard thing to do because what you see listed here are very complex systems, very complex industry. I would argue that healthcare is more complex than any of those other industries. No offense to nuclear power or naval aviation, but we have some variables, I think, that other industries do not have, starting with the patient. A high degree of variability comes in the door every day. All right. Oftentimes, we don't know what to expect. We have to discern that patient by patient by patient over time. So what do we do as learners? What do we do as teachers as we try to sort of look at that variability and see how we can reduce it. Okay. So if you look at something like an aircraft carrier, I don't know if you've ever seen an aircraft carrier floating in the ocean, but they are not stable. Okay. Wind, ocean conditions, jet speeds, pilot conditions, all this goes into variability of landing a jet on an aircraft carrier in the middle of the ocean. Healthcare has the same thing. The health of the patient, like we just discussed, equipment, training, the condition of the staff, the training of the staff, the room setup, cleanliness, on and on and on, adds variability. As we learn, hopefully we keep in mind how we're learning to address these variabilities that we have in our systems. So high reliability organizations overall operate under these very trying, complex conditions, but yet manage to have fewer than their fair share of accidents. So not only do we have to care for the patient, not only do we have to manage the environments through which we care for them, but at the same time, we have to reduce error. We have to reduce safety events. Oh, and on top of that, we have to make sure that they love every single thing that we do. All right. So if you're a patient and you're in pain, you need surgery. All right. You need to be healed. At the end of it all, we ask in a survey, how well did we do it? Okay. And it's the perception of how well we did it that is the ultimate determination. So there's a lot at stake here. But like Dr. Haynes said, with value, what we have around patient experience, what we have around healing. Okay. Very important stuff. And it's all based on risk. All right. Risk is nothing but a probability of something happening and what's the consequence if something does happen. So it's a severity index. All right. So we have to identify these high risk propositions. And that goes along with the variability that we see in the system. Quickly, there's ways in which we can reduce this. All right. Improving our reliability. Reliability is nothing but how well we perform a standard. Right? How reliable we are to a process. That blue box on the left is your reliability. Your reliability goes up, the number of nonconformities or errors you have per million opportunities, let's say, goes down. Okay. That's the whole idea behind Six Sigma. You may have heard of Lean Six Sigma. So as your reliability goes up, your propensity for error goes down. We want to optimize outcomes, in other words. But in order to optimize outcomes, we must improve processes. So we have to measure the processes themselves. And how do we improve that? The first thing we do, and in healthcare, we have really good process design. Day to day, when we're embedded in these processes, we may not believe it, but we do. Right? We have very good processes for how we care for patients and how we care for families in general. The second level in which we can increase reliability is reliability culture. We just talked about that, how we build a culture to drive all this. And the third level in which we can improve reliability is human factors. How do we design environments and electronic systems, all right, to help us improve care, right? And healthcare is scratching the surface of human factors. And this is where engineering and clinical acumen really meet. And we have examples over and over and over again in healthcare where that's being accomplished. So how do we measure quality and safety? One, it's a reduction strategy. We reduce harm. Okay, we'll hear some really good presentations of how we do that very specifically today. And then there's something in engineering called increasing yield. Okay, in healthcare, there's financial yield. There's successful yield of volumes of different things that we have. But I also like to think of increasing yield, not so much in a manufacturing sense, but looking at yield in the things that we just mentioned. We have a yield in safety. We have a yield in quality. We have a yield in patient experience. So how we manifest that yield and propagate it's very important. But a lot of what we do in safety is reduction strategy. We reduce infections, we reduce falls, et cetera, et cetera. But in order to reduce something, we need to increase something. And that increasing of something is compliance rates with our processes. Okay, so that's very important. And at the end here, I'll show you some of the methods we use in order to do that and how we have things that can help you do that. In order to set the stage for this as an organization, throughout the healthcare system, not only are we accredited by a deemed body from CMS to make sure we're meeting those conditions of participation to call ourselves a healthcare system, but we also design what are known as quality management systems. Quality management systems are just a set of criteria, and it's ISO 9001. That's the technical name for it. But it's just a set of criteria through which we build a quality management system, which is really our strategic business model, all right, of which quality is the main driver, all right, on how we set this in place for the organization. So again, it's a set of standards, it's a set of criteria through which you build foundations and build structures in place to handle everything that Dr. Bennett was talking about and what we do on the hospital side. Quality management systems very easily is an input-output system. Okay, you have system inputs of things that go in, right? The patient, the voice of the patient, all right, problem lists, your high risks, opportunities for improvement, regulatory expectations, staff expectations, community expectations. A lot of things go into your inputs of the system, and they go into what I call the quality management system engine. Each one of those circles is a piece of the engine through which we provide quality care. Okay. Starts in the middle with leadership. Leadership strategically plans and resources all this. All right. Dean Haynes is involved in that on the college side and worked with Mr. Coleman and others on how we provide resources, all right, not only to provide great care, but great experience. So we have to support this through operations. And leadership gets an added bonus. They get to evaluate and oversee and evaluate through management review how well this is occurring, how well the quality management system is working. And if there's gaps to where it's not working appropriately, we go down to the red circle, okay, which is improvement. And hopefully, as we go through this iterative engine cycle, we'll get to the right, on the right-hand side, which is quality outcomes, the good system outputs, all right, zero harm, regulatory compliance, satisfaction, staff satisfaction and retention, and of course, community and financial value. The beauty of all this is not only do we have to set these structures in place, but we have to measure it all. Okay. The only way that you can identify whether or not things are working appropriately is you have to measure it, right? So we have quality analytics. We have different types of analytic programs, both in the college and on the healthcare system side, on the operational side of how this occurs. This goes all the way up to the board, and the board actually sets a lot of these strategic objectives in place every year. And here you see some examples of that. Everything from inpatient and medical practice patient experience to ED length of stays and case mix adjusted length of stays and fun things like that. We measure this on a very regular basis to see how we're performing. We also do this with harm. Use a lot of heat maps, okay? This is our journey to zero harm heat map. So everything in blue means for that unit, for that hospital acquired condition, we had zero. And then you see popping in yellow and reds is where we've had hospital acquired conditions. Things like infections and falls and med errors, et cetera. So we monitor this, and this gives us the roadmap of where the opportunities are, okay? And that goes into the engine, and we prioritize what needs to be worked on. So again, the gravity of the situation is a lot of this applies to harm to patients. IHI defines a culture of safety around reporting of safety events. Many of you are aware of eSafe, which is our electronic event management system. We have a whole patient safety oversight team, of course, with specialists that look at every single safety event that's put into the electronic system. Okay, so it's very important that we find out about these things. Once we find out about them, we have a very specific system that we go through for causal analysis, really driving down the causes of the events themselves. On the left, you'll see what is known as the root cause analysis 3 meeting model. Right? We have a very specific way in which we run meetings and we get information from meetings, how we do interviews of those involved, on and on and on. At the end of that are 2 things. One is, of course, setting action items so those events hopefully in the future do not happen again. The other thing we do is on the right-hand side, and that is the classification of safety events. This is the ultimate safety metric, if you will. Starting at the top, we have, of course, the rarest of events, and that would be your serious safety events. This is where we would have a gap in generally accepted care. It reaches the patient, and the harm results in moderate to severe harm or death. And on down the pyramid, we get down to the bottom, which is just near miss events, where something didn't even reach the patient. But if it did, all right, it's kind of predictive, if it did, it had the possibility of causing harm. That's where we learn. If we can start catching things before they reach the patient and we can predict that it would have caused harm, that's where we really are getting in front of the curve. Okay, so how do we teach to this, right? How do we teach learners about this, right? How do we put a situational awareness in place that this is the way we should be thinking as we provide care, right? That's what high reliability organizations do. That's what we do, right? That's what ACGME expects us to do, right? Is train faculty and learners to embrace this, embrace the quality improvement. So there's very specific ways in which we do this, very standardized ways in which we do this. First, we have to define what our key processes are. We have to manage those processes. And as we manage them, if we see room for improvement, like we're saying, then we kick in, right? That's that red circle at the bottom of the engine. So we have specific quality tools, and I won't belabor them today because that's a whole 2 or 3 hour session. But we have quality tools like Lean Six Sigma tools, plan, do, study, or check and act cycles, which are rapid cycle tests of change, and things like statistical process control. How do we analyze trends in our data? There's very statistically relevant ways in which we look at trends in data. So we have a lot of things in our toolkit for how we approach improvement. And this is all through the auspices of project management. Over here on the right, we see something we use called DMAIC, which is just an acronym for define, measure, analyze, improve, and control, or sustain our improvements. So we work through a project going through these different stages of DMAIC. So we're very organized in how we do quality improvement. And that's something that we want to make sure we embed also within the ACGME structure and how we build and develop teams in this way. So we do have educational opportunities. Like you saw in the data, we have opportunities for improvement to be involved in left and right, right? Most of this is what I would call fine tuning, but there are things where we're creating brand new systems to improve care. So we have a curriculum of sorts, trainings that are available. First is quality improvement methods, just didactic trainings for leaders and faculty and residents and fellows, where we can do just regular sessions like this. But then we have quality improvement coaching and tabletop exercises, okay, workshops, where you bring in a problem and we work through it together on the tabletop as an exercise. And this usually takes an hour and a half to 2 hours. We work through a problem and start implementing some tools that may be helpful. I know we've done this with academic internal medicine. We've done some of this, Dr. Bennett and myself have done this with family medicine. So this is totally available if you want to see this, not only on the learners, on the resident side, but also on the faculty side. One thing that we're getting together is how do we do this for faculty as well. We also have trainings on statistics, everybody's favorite, bring a lot of coffee. Data visualization, how do we graph data? How do we do trend analysis? I mentioned before statistical process control, sort of the fancy engineering way of looking at trends. We have training on safety culture and high reliability. That may seem sort of abstract in a way, but there are very I would say basic ways in which that's very functional with what we do every day around high reliability. And we have standards of behavior and patient experience training. The patient experience team, Christina's a part of that with Marcia Collier, doing full scale training around experience with the EDs. Right now they're working with the folks at East, They've done some Baroness training, and then we're going to be doing the same training with nursing staff coming up in the spring and summer, which will encompass well over 500 trainees. That is also available on the faculty side and the resident and fellow side. So a lot of good information in that regard. Pretty much everything I just talked about is on our intranet. If you go to the top of the main page, on the top left, right below the Clower there, you'll see a quality, safety, and service link. If you click on that, you'll see a large amount of our data that we have by campus, by unit. That's there in the purple and in the bottom right. But we also have quality tools and templates there, and on and on. We have a meeting every month. It's actually this Wednesday at noon. It's called the Quality Oversight Communication, or the QOC. And that's where it's sort of a highlight or a spotlight for quality projects in the organization. Okay. This coming week, we'll be looking at antibiotic stewardship. So I have a presentation on that, as well as some other things. So all this is available when we do the tabletop exercises, et cetera. We utilize the exact templates and things that we have posted here for you. And with that, I know Dr. Bennett as well would be happy to answer any questions, but we thank you for your time this morning. Look forward to a great program today. Dr. Bennett.
We've got folks in the room from all kinds of areas and different backgrounds and work responsibilities. Did anyone want to make any comments at all or ask any questions? Thinking that the notion of all teach, all learn starts with a questioning mindset. So we're going to create opportunities for any comments. Yes, sir. Dr. Mannion.
So this is a great presentation. Just a question. So when you think about the aviation industry aims for a number of zero events. So the aviation industry aims for 0 events of harm. So in healthcare, I think we also aim for 0, except the number of variables you're trying to control are much higher. CLABSIs and CAUTIs, which when I saw some of that data, there are national kind of, curriculums and presentations on people going to 0. What is our plan to move towards that?
Absolutely. Thank you, Dr. Mannion, for that. It's a very important question. The question was, what are the plans in place to kind of get to the nationally recognized standard in some areas like CAUTI and CLABSI, where there's a lot of 0 harm involved. I give a good example of on the children's side. Dr. Bennett can speak to this as well, and we'll hear actually some of the work on unplanned extubations today. Is the Solutions for Patient Safety collaborative, where there's very standardized bundles of care that are scientifically tested and proven that if they're implemented appropriately will lead to 0 harm. We're seeing large amounts of 0 harm in infections, in unplanned extubations, et cetera. So given the complexity of the system, it may seem like it's, to arrive at 0 consistently is very hard. But there are bundles of care. There are things around the processes that we can put in place. And of course, that's collaborations between physicians and nurses and respiratory therapy and many other folks. But that is really what we work on, what we focus on, is how do we drive the process change to make that happen. It happens in Solutions for Patient Safety. It's a whole national collaborative network, but there's other collaboratives that we're involved in that help us put those processes in place. And the quality improvement that we speak of, a lot of it is focused around that type of process orientation. So while we see a lot of zeros in our data, we always strive to make that heat map totally blue. And it's an aspirational goal. We know that due to the complexity of the system, there's going to be harm that will be involved, unfortunately, but the more and more we drive to 0, philosophically and functionally, I think it's all the better. Any other questions or comments?
Yes, sir. And feel free to use the microphones and all that. I failed to do some housekeeping early on, but unless we're using a microphone, we can't pick up in our recording this important part of our gathering.
Thank you for the talk. The last few slides, there was a section where you said some resources were available. Are those like led by an instructor in the department? I think go back to that one. Or for example, someone could come and speak to departments on the statistics for quality 101, or is that
Absolutely. Yeah, I appreciate that. So we can reiterate this point, this most important point, I think, in the presentation is what we have available. Yeah, that's something that Dr. Bennett and myself can help with. All the things you see on this, you can just contact me and we have slides and curriculum ready to go. We just find a mutual time and we're off and running. So it's formed, it's ready to go at your leisure.
And I think one of the, historically, we've thought of this as a curriculum. We've thought of it as sort of a product that we're trying to deliver to residents and fellows before they leave us. And one of the big questions now is, so if you're working within certain environments a lot, we have a fair number of clinics that are primarily staffed by residents or fellows. And how might we engage with that entire environment more effectively? So rather than kind of a piecemeal sort of educating residents and fellows over in this classroom and perhaps nursing staff or other stakeholders in another classroom, and then somehow expecting that's going to come together in a really organized way, maybe we should reframe how we approach this. Maybe we should think about that clinical learning environment and those who provide care there and try to develop them and that space to be a little bit more effective over time. One of the challenges, of course, is there's always going to be constraints on resources. So we want to figure out how can we best apply the resources we have. So partnering with residents may actually look a little bit different going forward. There's a lot of detailing that we're trying to do with our quality champions. And as we go forward, we're going to try and sort out, first of all, what are the common things that all of us need to understand more effectively? And when I say all of us, I mean everyone who's working there to the benefit of the patient. And then are there some unique characteristics in certain learning environments that need to have some special thought? So thinking of it in the way many manufacturing plants do, where they'll build multiple products off a similar chassis. There's a lot of commonalities in what we do, whether we call ourselves surgeons or internists or pediatricians or you name it. There's a lot of commonalities at the end of the day in the services we provide and how those things are structured. So there's a lot I think we can do in partnership. And as Dr. Campbell said, the solutions for patient safety, the real secret sauce there is as an organization cracks the code, they are quick to share what they learned and make it available to everyone else. We're not in a competition with one another. We're trying to help each other get better. At the end of the day, we're all in the same game. So internally, we can have the same mindset as well. So as individual clinics or operating room environments or whatever, find solutions. We want to create platforms to where those solutions can be shared across the organization, because there's a lot of things that can be adopted or adapted given the incredible talent that we have here. So this is an opportunity for us to think differently in terms of the deployment of how we do this, but also how we really engage that teaming at the local areas, local level. And as far as this piece right here, this DMAIC thing, it's kind of foreign to most folks in healthcare, this construct of Six Sigma, unless you came into medical school through an engineering background. But really what this is a diagnostic journey, which we do a lot of. And Dr. Campbell mentioned that the biggest source of variability is the patient who walks in the room, and really understanding where they are and better being able to classify what the problem is, so that the things that we decide to do with them are more likely to be effective. Well, DMAIC or PDSA, it's the same idea, is we typically don't start with our solution. We don't start with our treatment plan. We start with questions and with an open mind. And we work toward a better understanding of what's going on so that when we propose a solution, it has a higher probability of success. This is exactly what we do all the time. So it's really just a little bit of different nomenclature, some slightly different structures in terms of the questions we might ask and how we use data. But the point is exactly the same. And I think there's a lot that we can bring to the table as providers that will accelerate how this plays out where we do our work. So I really look forward to working with everyone here. Dr. Campbell brings a lot to all of us. And now that we over in the college are deepening that relationship and that shared commitment, I really feel like we're going to see better yields out of this going forward. Any other comments or questions? We've got some other leaders in the room. We've got some folks who do a lot of the frontline work. Anything that's coming to mind? All right. Well, what I'm going to do real quick is I'm going to throw up our previous slide here. Let's see if I can get out of this one. I like to throw this up as often as I can so that people can make use of it. The next part of our gathering is really the big deal. For those who do want CME credit though for today, make sure you do use this code and give us feedback. If you've signed in, we can put you in a real strong position to get a few hours of credit for being here. For the purposes of the presentations that follow, for those of you who have questions or comments, we're going to invite you to kind of queue up behind the microphones that are in that central hallway there in the room so that everyone can hear you as well as we can record the question or comment as well as the response. So is that good? All right. Well, with no further ado, Dr. Campbell is going to step in and introduce our judging panel.
Oh yeah, we have judges for all this, right? Fun stuff. Time for the, I would call it the friendly competition part of the day, of the morning. As we know, we have 6 presentations this morning. We have 3 judges that will be sort of looking at those presentations and how they espouse quality. We look at the outcomes and how it really drove sort of improvements in care, et cetera. And then at the end, we will deliberate and have a winner of sorts or best presentation with all the rights and benefits there too. So I'd like to introduce the judges this morning. First, we have Amelia Jones, Director of Volunteer and Guest Services for Erlanger. Thank you, Amelia, for being a judge. Christina Harness, who comes to us from our patient experience shop, and she's a patient experience specialist. So thank you, Christina, as well. And Melissa Ellis, who is our quality program manager for imaging. So welcome back to Melissa and being a judge again this year. So what we'll do, again, the judges will, we have little rubrics that we'll follow, but we'll be listening intently to the presentations and then scoring some points and deliberate at the end. So very low key, do not get nervous about all that. Just something we like to do to really give some recognition to those who have really been driving the quality. All right, thanks, Joe.
And don't forget your hat. All right, gang. Well, our first presenters this morning, kicking this off, is Dr. Thornton here? There we go. All right. Everything should be set for you guys.
All right, good morning. I'm Dr. Thornton. This is Dr. Rotondo. Perfect. All right.
All right, so our project, I'm sure everyone in this room has encountered a patient who's told you that they're allergic to penicillin. It's extremely common for patients to report that, and obviously there's cases where it's extremely severe, causing anaphylaxis. There's other cases where they were just told by their parents, hey, you're allergic to penicillin because you had a rash when you were a kid, or because you had diarrhea last time you took it. That's kind of the main issue that we were looking into was, okay, let's take our patients that we see in clinic and really deep dive who actually has a penicillin reaction. And if we determine that they don't have a true anaphylactic or type 1 allergy to penicillin, would it be appropriate to delabel them as penicillin allergic so we can use the penicillin type antibiotics in their care as indicated? As mentioned before, some people list the penicillin allergy and it just says in the chart other and doesn't really give you more information. Other people have anaphylaxis and have told you, yes, I need to use an EpiPen every time I take amoxicillin. Ultimately, clarifying this would ideally allow us to, one, select the proper antibiotic for certain conditions, and two, avoid unnecessarily escalating to a further level of care beyond just simple amoxicillin or whatever else would be indicated due to their penicillin allergy. And with the goal in mind, better patient care and to potentially decrease side effects or furthering antibiotic resistances. So what we did is we took the patients that we see in our clinic. A few of us, myself, Dr. Noggle, and I believe Dr. Choi from last year, who actually presented at QIPS Day as well. We called patients to go over the signs and the symptoms and when the event happened with the patient. And that was using what's called the PENFAST criteria. This is something that is readily available on MDCalc, and it's essentially a 3-question survey for a 5-point system. And the 3 questions are, was the reaction in question 5 years or less, or more than that? Was the reaction anaphylaxis or angioedema, or was it like a severe cutaneous adverse reaction like TEN or something along those lines? And then the last question is, did you require treatment for the reaction, which is a little bit non-specific because some people just receive Benadryl, some people receive an EpiPen or 2, but it's fairly vague in that regard. But depending on how you answer the questions, you get 2 points for the first, 2 points for the second, 1 point for the third question, scored from a scale of 0 to 5. If your score is 0, it's a less than 1% chance that you'd have the reaction. If you scored 1 or 2, it's a 5% chance that you actually have an anaphylactic reaction. If you scored a 3, it's about 20%. If you score a 4 or 5, it's 50%. So using those criteria, we just go over that with the patients and see where they're at. And then about 9 months later, we did a follow-up, which is basically just analyzing those patients and seeing those patients that we felt like it was reasonable to delabel them. Did we do so? Did they agree to do so or not? Was there another reason that they were ineligible? And did their chart remain penicillin non-allergic? So what we hope to see with this was just consistency with our protocol, kind of following the PENFAST criteria and then educating patients about it to see, are you delabeled? Are you not? And then are you persistently delabeled down the line?
So these causes leading up to this problem that we looked through, there's a whole lot of them. This is just some of them for each patient. There's problems with medical literacy. They may have attributed this to the wrong antibiotic or medication that they were taking, minor reactions that wouldn't have really triggered a real antibiotic allergy. The timing of it, maybe they had it when they were a kid and their parent told them about that, but they don't really know what those details were. Anyone can add these reactions into the EMR. So it could be a knowledge gap with staff, lack of confirmation on those things, or even who's the incorrect patient that was placed on. How those things were communicated with, via the telephone. We weren't able to verify those problems with language barrier, mental capacity. All those were problems that we saw leading to inappropriately labeled penicillin allergies. So these measures that we were evaluating in terms of the outcome, the overall burden of listed penicillin allergies in our ETFE patient population is this really overall measure. Specifically, we were wishing to eliminate the inappropriately listed ones or this 9-month follow-up from the initial delisting. And the process measure here being the proportion of the reported allergies that were deemed inappropriate and delisted remaining delisted versus being re-added back on at that 9-month window. So for the full PDSA cycle, in terms of our plan, we had the data collection of likely inappropriate allergies. And then for the due area there, per the PennFast criteria, inappropriately labeled allergies were delabeled with patient consent. And in the study section there, review was conducted at 9-month follow-up to quantify the number of reported allergies remaining delisted. Those are all the things that really happened during this whole cycle. In italics there, we could see what could happen in further iterations kind of these cycles. So evaluation of the allergy listing and the diagnosis process is part of what we're talking about now. And then in the act there, the initiation of the clinic workflow to standardize diagnosis of new penicillin allergies, and for undiagnosing inappropriately labeled penicillin allergies, it's one option there. So in terms of our overall results here, about 614 total patients were contacted. Of those, 152 were unable to reach despite 3 phone calls. So the total there being about 462. About 66 of those were unable to participate. It could be for a whole variety of reasons, being dementia or not really able to have a meaningful involvement in the interview. Pregnant patients were they were excluded, factored out. Pediatric patients as well. And then 19 and just a whole series of other smaller causes. So the total eligible were 396, and those that declined was actually 359. And so a huge number, but those that were ultimately gave their permission to their consent to delabel was 37. And the interesting thing there being that after that 9-month follow-up, only 3 were ultimately had the allergy added back on because of some kind of event during that time, and 33 were not. So, and 1 was lost to follow-up. So pretty good overall. In terms of what we noticed here, let's say the project was very successful with 89% of those patients were able to be delabeled through the PennFast protocol, and they did remain delabeled during that time, which suggested that using a robust protocol, it really leads to a durable result for this process. Ultimately, over 7% of the patient population that we were able to contact during the study, they had an allergy that was delabeled that remains delabeled, showing that our project did have an impact on our clinic's antibiotic stewardship. Our project also increased provider awareness that is okay to discuss with patients the potential validity of their allergies. This is important because labeling an allergy in EPIC can be done by anyone with clinical chart access, with potential implications of incorrect labeling of drug allergy. Once in their chart, allergies are typically not questioned and often interfere with prescribing first-line medications. And this empowers providers and patients together through shared decision-making to make a judgment on risk of a potential reaction versus benefit of use of a first-line medication with potentially fewer side effects and less societal harm. Kind of barriers and lessons that we learned were that it is difficult to reach these patients. We did use a standard 3-call system to reach patients for data collection. It's shockingly easier to reach a patient to give them their lab results than it is to bring them in on a study like this. But patients' refusal to delabel is another problem. Despite adequate understanding and counseling, just a huge number of them still refuse to make that change in status just because their own nervousness about what could possibly happen. Poor medical literacy, I think, is part of this. Was overcome as best as we could with just really consistent patient-centered education. And HIPAA compliance is just hard no matter what with all of this and doing research. So the kind of the next steps, like we alluded to earlier, numerous options for future cycles for this. Could repeat this with a new patient outreach and follow-up, see how those numbers differ overall, evaluate the system for who most commonly is adding new allergies into the chart, whether it's other physicians and these DOs, the MAs, the RNs, patient care techs, whoever, and then see with cycle testing the addition of this with so evaluating the whole system for who's adding this and seeing if using a criteria checklist, possibly with a PennFast criteria or their education, to see if this would impact how these the amounts of new allergies that are being added, or even trial a patient-driven delabeling education campaign via possibly my chart, handouts, posters, whatever, to see if that could help to have a different outcome overall. So, we have us who all were involved in this, Dr. Choi from last year, and Dr. Gunn, our mentor, then also Dr. Bradford, who was really, really instrumental in making this project possible. So that's our project overall. And any questions about that?
I'll just be loud and ask. When you made the calls, was it a team of people or was it the patient's primary provider, primary doc?
So it was myself, Dr. Noggle, Dr. Choi, and one of the pharmacy residents last year, I believe Kathleen White, were in charge of contacting the patients on whatever information we had available for them.
I think it was, and I think it was, yeah. With the data, it was the PCP that was connecting with their specific patient.
Oh, really? So the actual cold call was the patient? I mean, the PCP.
And in at least a third of those cases, yeah, it was just with Dr. Choi's.
Because I'm wondering, one of the next steps could be out of the people that refuse delabeling is to get to their PCP and have a face-to-face, maybe.
I think,
yeah,
just study that component.
yeah, I think that's a good idea to have a little bit more trust there on the patient side to go through that process.
So, I think that was a great study. I think your primary objective was met. There were a lot of people that fell out, like you talked about. I think it was 396 patients fell out because they didn't want to be delisted, right? And so it'd be interesting to see if you can take this the next step and look at the patients that you did appropriately delist as a penicillin allergy, follow them up and continue them, and to see how many of those patients actually get penicillin down the road. Then use that data to convince the 396 patients to say, hey, these are the patients that actually it happened with. Now, it may not be in your tenure here, but it would involve you. And I think that would be a good project to then show, nationally as some data to prove to patients, hey, we've done this and this is something that's beneficial. So just something to consider.
And just a brief comment there. I think this was more presented last year when Dr. Choi talked, but for those patients that either it was appropriate to remain penicillin allergic or those who refused to be delabeled, we did also offer a referral to allergy and immunology. Some of them may or may not have actually created that follow-up, and obviously we haven't followed them into that setting to confirm what happened there. But that is something that we at least offered for some of those patients.
Anybody else have any comments or questions? Well, thank you very much. Well done. Ready? Okay. Next up, Dr. Johnston from Pediatrics.
All right, guys. Hi, I'm Brittany, and I work with Dr. Benjamin Reed, who's in the NICU for this project. It's a multi-pronged approach to decreasing the length of stays of neonates diagnosed with NOWS, which is neonatal opioid withdrawal syndrome, also known as neonatal abstinence syndrome. It's kind of gone a makeover with its name. All right, so for those of you who are not as involved with our smaller members of the community, NOWS is an abrupt discontinuation of the fetal exposure to substances that are used or abused by moms during pregnancy. They have a lot of different exposures and different what's the word I want to use? Effects to the infants, like neonatal issues, problems with their milestones in the future. But one of the things that kind of comes down to that the hospital system really gets interested is there's a really high cost to these long length of stays for these patients. It's somewhere around $53,000 per patient per stay. And these are not really well reimbursed stays. So this is kind of a loss for a lot of our NICU grads here. Usually when we look at going ahead and treating these patients as like a two-pronged effect, one of them is using our pharmacological agents. So our morphine, our clonidine, phenobarb, these have effects that can really kind of follow these patients long-term. But we don't want to leave them kind of withdrawing and dealing with it from that aspect. And there's also another prong that's a lot less used for non-pharmacological agents. So these are things like soothing, skin to skin, low stimuli environments, which is obviously better for our infants, but harder to provide in the hospital setting. So it's kind of feeds into where we are now. In Tennessee particularly, the NOWS rates had really increased, kind of looking at the 2016, 2017 rates from somewhere in 17 to 13 to 16 in 100,000 live births. It's kind of climbed down a little bit now. This project was started in 2022, so we didn't have all of the data that we have now, but it still is a really big group of this population in the NICU. So when we looked at the average length of stay in the country, it was about 14 days. 2 weeks, not too terrible. When we looked at ours, it was 26 days. So almost double, and really a place that we could improve for both our patients, our NICU, and our budget here. So our main project aim was really to look at decreasing that average length of stay in neonates with NOWS by at least 50% from average to from 1 month to about 2 weeks. That was our lofty goal that we kind of looked at going towards. Our kind of subset aims were increasing initiation and really consistency of our non-pharmacological therapy, because we saw that we weren't using these as much as we could. We wanted to maximize our pharmacological therapy. We wanted to capture these babies early and then wean consistently to shorten the stay. We also just wanted to get everyone on the same page. I've put NICU personnel here with as long as the families, but I really do want to include newborn nursery as well, because we do have our babies going there and ideally staying there. They don't need the pharmacological agent. And then we also wanted to modify our current protocol that was kind of aged and really could do some revamping, really looking at how and when we initiate any pharmacological agents, and then how we can really introduce those non-pharmacological agents. So these are some of the things that really we looked at that increased the length of stay. Some of them were in measures. We used the Finnegan scoring to kind of see how badly our babies are withdrawing. It is notoriously really poor inter-rater reliability. So you'll get one nurse that is looking and they're seeing and their score low, they score maybe a 2 or 3. And then you'll see another nurse, same shift, the baby might look the exact same and their score over a 7, which is above where we would start treatment. So there's really a lot of difference that we can see there. There's also a lot of difference in how we document the dose. So a lot of it is like per kilo or per absolute dose, and that was just causing a lot of confusion. Environment was also a really hard difficulty for us. We have an open pod concept, and when you need low stimuli, quiet, all of those things, that doesn't work very well for NOWS babies. So that was a difficulty. We also worked, we had a really high census and low staffing. So when you have lots of babies who need a lot of care and not a lot of staff, it's hard to kind of show that these non-pharmacological agents that really help but take a lot of time are going to be your first go-to. And then some of the difficulties with personnel is that it's a hard subset of patients. There's a lot of built-in prejudice. It's hard to engage some of these families, just kind of depending on where they fall in this spectrum of drug misuse or abuse. So those are some of the things that we really built and based our PDSA cycles on. So our main outcome measure is how long are you staying in the NICU? And then some of our other measures were how long are you actually on pharmacological therapy? How much of the pharmacological therapy did you need? What was your actual Finnegan scoring? And then did they use the non-pharmacological agents? I will say that it was really difficult to get the information from that last subset. Even just using breast milk was hard. It wasn't well documented. And then here's kind of where we started with our project. We did neonates who were greater than 35 weeks diagnosed with NOWS through infant drug screens to either our NICU here or over at East. We did over 35 weeks because if you're younger than 35 weeks, there's a lot of other co-founding kind of factors that play into there. So this would give us kind of more pure data. Our first cycle was really working with the staff in the NICU and mother baby nursery to talk about what are our non-pharmacological methods, are we using them? And then we introduced eat, sleep, and console scoring, which I'll kind of talk a little bit later. But it was kind of more of an educational, let's get everyone on the same page. Let's kind of find out where issues were. And we did a survey that was not well kind of responded to. So I kind of went out and just asked a lot of people in there, and there's just a lot of confusion and a lot of feeling like there's not enough time to take care of the baby. So that was kind of the issues that we discovered really in that cycle. Our second cycle, we changed our initial morphine dose. So we increased from 0.05 mg per kg to 0.1 mg per kg after we talked with our pharmacists and our NICU providers and got them all on the same page and to buy in. And the thought with this is that we're going to get to our capture dose sooner. We're not kind of trying to find that capture dose where these babies are not having all of these withdrawal symptoms, and then we're going to be able to wean smoother. Our third cycle was looking at retrospective data from 2018 to 2022, kind of paired with a survey of the neonatologist, trying to figure out where their frustration and confusion was coming from. On the right for you guys, you can see that on the first kind of breakdown of that survey, there is a whole lot of different subsets that people kind of look at when they're looking to wean. So there is not a good consensus. And then we just wanted to see if there was buy-in. Should we do this? Are people going to do change the scoring system that they've been using for years to this new scoring system? And a lot of people were really interested. So we kind of moved forward with that. And in the same cycle with that information, we went and we revised the protocol with the help of our pharmacist to have a more standardized escalating and weaning process. And then the fourth cycle we are still in the middle of, we are working on moving from Finnegan scoring, which is like a 7-question scoring. Like I said, it doesn't have good inter-rater reliability, to this new eat, sleep, and console scoring. It's been done at several other hospitals, but it's much more simplified, only a couple questions. You don't have to wake up the baby, so you can just kind of do this scoring much more easier. It's at our East Campus right now, and we're looking at Finnegan scoring kind of head on to the East, or Eat, Sleep, and Console scoring, making sure that we're not missing any babies that should have gotten treatment. And since it's at East, we're having slow mark of our babies coming in there. So we haven't gotten to move it over to our main campus right now. And these are our main results we kind of had for that. A lot of them were kind of overlapping cycles, but we had our length of stay decreased to 19 days from 26 days. And that was really kind of after that initial dosing that we saw. So after the second cycle, so not quite where we aimed, but a really good decrease that we're proud of. And then the other thing that we saw is after we changed our protocol, we were looking at how many of the adjunct therapies that we have to use. And we went from using phenobarb and clonidine to really cutting those out for the majority of babies, and much more babies who are needing that pharmacological therapy were only having to use morphine, which has a better kind of side effect results. All right, so these are the conclusions we kind of went to as we were looking at all of the data and where we were now, that if we have earlier management of these withdrawal symptoms, whether it is pharmacological, non-pharmacological, we decrease the length of stay, we decrease narcotic exposure, and we decrease using that adjunct therapy. There are a lot of limitations in this study. There's a lot of staffing and resource limitations. We can't just build a new pod for these babies, which is what we all really wanted to do. We wanted to have a lot of new nursing, or not new nursing, more nursing, to really kind of interact with these babies and do more of the non-pharmacological swaddling and things like that. Other limitations where there's a lot of coexisting conditions, there's a lot of like multi-exposure babies. So it's kind of hard to say, and we tried to figure this out looking through the data, and it really wasn't clear. Does this really work better for our one drug exposures versus our polypharmacy kind of exposures? And then the open unit of NICU style, and going and just really getting your buy-in from everyone. There's a lot of people who are affected in the NICU and mother baby, and it was a lot of different changes, and going from what you're used to doing to a whole new system was difficult. So our future plans, as you can see from the graph on the side, the opiate use in just the regular population is still going up. So this is still a problem that's not going anywhere. It's still going to need to be looked at, and so we can give our babies with NOWS the very best of care. So we're going to continue to work on transitioning Finnegan to Eat, Sleep, and Console, hopefully at the main campus. We also hope to collaborate with OB, so we can really hope to kind of get parents education in early. So we can work with that, and then working to really get parents engaged through our own education so that they can feel more empowered to take care of their babies, to be able to help their babies through the withdrawal. And then I really want to thank Dr. Benjamin Reed and then Renee Hughes, who is the pharmacist who really helped with this project.
I've seen this conundrum play out across the country. And I wondered, with respect to networking, has your group been able to kind of work alongside any other neonatologists, perhaps elsewhere, and other teams, and kind of get some thoughts or maybe share some thoughts?
Yeah, so East Tennessee Children's really kind of takes the higher volume of the babies with NOWS. So we kind of reached out with them. A lot of our neonatologists have worked at both places. It's a problem for everyone. I don't think everyone has quite figured out the best way to go about this. So they're kind of asking us well, how we did it. We're asking them how they did it. But I think a lot of the initial actual doses are used, we use from different programs who had seen success with them.
Just out of curiosity, what proportion of NOWS babies are at East versus at our main campus?
Oh, I do not know the number, but I know the vast majority is over here versus at East. Usually if they need pharmacological therapy, they're transferred here.
Okay, so the bigger bang for the buck, so to speak, will be when we deploy this in this campus. Okay.
Yep.
All right. Does anybody else have any comments or questions at all? All right, nice job.
Thanks,
Thank you.
guys.
Sure. I got it.
Sorry.
All right. All right. Now we have Dr. O'Brien from pediatrics.
All right, I'm Dr. O'Brien. I'm a third year PEDS resident. Cole Atkins is actually on nights this week, so he's not going to be presenting with me today. But we also have Dr. Emmer and Dr. Bias. They are second and first year respectively that are working on this project. And then Dr. Garcia is our mentor. So what we were aiming to do was to improve vaccination rates in our resident run pediatrics clinic, specifically looking at walk-in vaccines, which we'll talk about later. So the overall goals. So the Tennessee American Academy of Pediatrics has goals along with the Bright Futures guidelines to do two different things as their primary focus. So combination 10, basically incorporating influenza vaccines into kind of routine standard vaccination. Because right now it's kind of flu vaccines kind of suggested, but a lot of people don't get it along with this other standard vaccines that they do get. So trying to incorporate flu into like a standard vaccine schedule by the age of 2. And also the same for HPV vaccine. So trying to get children up to date by the age of 13 on their HPV vaccine, in addition to the other vaccines in combination too. And this also is aligned with Healthy People 2023 goals, which objective 9 is to increase flu vaccination and objective 8, increasing HPV vaccination for children. So although our resident run clinic actually has pretty good vaccination rates across the county and the state, we still feel like there was improvement that could be made in our clinic, especially in the walk-in clinic, because a lot of times the focus is on the chief complaint, more of like a urgent care kind of setting, and less so on necessarily getting vaccines caught up during that visit. So if you look at this here at the Tennessee vaccination rates, flu is 64%. In our clinic, it was 58%, and HPV was about 53%. And in our clinic, HPV vaccination was about 57%. So pretty decent, but still room for improvement. So the current situation, again, like I was saying, it's always good practice to look at vaccine records and see, which vaccines are children behind on, but it doesn't always get done. Sometimes if the chief complaint is quite obvious to what the diagnosis is, we don't necessarily do a thorough review of a child's vaccine status and try and get them caught up on everything. So that was a goal for this project, was to try and pay more attention to these and kind of opportunities so that these children aren't getting missed and getting further delayed on vaccines. And so based on our baseline data, looking at children in the walk-in clinic, only 13% of the kids that were coming in that were behind on vaccines got at least one vaccine during their walk-in visit. So our aim was to improve from that 13% to 20% by the end of last year, December 23. We also wanted to improve the overall vaccination rate in the clinic to by 5%. Also in line with the Tennessee American Academy of Pediatrics goals. And so the thought was that by increasing vaccination status in the community, we would provide better coverage for vaccine preventable illness and also increase herd immunity in the community. So there's a lot of different things that go into suboptimal vaccination rates for children. So under people, parental beliefs, fear, misinformation, someone's culture or religion that may advise not to get vaccinated, environment, so parents having to take off from work, parking availability, getting the kids out of school, that always all plays into whether parents are going to bring their kids in for extra visits just to get vaccine catch up. As far as equipment and materials, are we keeping good stock of our vaccines? Are they expired? Are they available when kids come in and need them? Also, do we have accurate record keeping with tennis, and is everything up to date there? Kids from out of state, are their vaccines up to date, and things like that. And then also methods, just a lot of vaccines, like administering vaccines for kids, is discussing them with the parents, making sure parents understand, why we're vaccinating for these, even though we don't necessarily see these diseases anymore. Why it's important to continue to vaccinate, and then also giving return precautions and things to look out for so they don't get concerned if their child has a low-grade fever or a knot under their skin after vaccination. So discussion with parents is very important. So the measures we looked at, so we wanted to overall improve the vaccination rates for kids who are eligible in our clinic, specifically looking at flu and HPV like I discussed before. So our goal primarily for the flu was to get at least 2 vaccines done by within the child's first flu season. And then also HPV, we usually start the series at 9 in our clinic. So it's really getting children to be started at 9 years old. And then process measures, we were looking at the percentage of children that were behind that actually did get at least 1 vaccine during the walk-in appointment. And then as far as a balance measure, we mainly just got verbal feedback from residents and staff about what the changes we were trying to implement and how they felt about it. So the 2 PDSA cycles we had, the first one was looking at discussing vaccination status in the huddle. So every morning before clinic, before patients arrive, we have a huddle to discuss any needs that we have, stock of vaccines, staffing issues, anything like that. And so discussing the need that all the residents and the staff needed to review a patient's vaccine status in the walk-in clinic prior to seeing the patient. And then also we were wanting the nurses to put on the whiteboards at the entrance of every door whether a patient needed a vaccine catch-up or not. And one quick way to do that is at the bottom left screen on Epic, and every kind of home screen of every child's chart is like care gaps, and it will tell you what vaccines the child is behind on. And so we didn't necessarily want the nurses to have to go into the chart and like figure out with tennis and everything specifically which ones they needed. But basically, if it was red, like it was being noted that the child needed a vaccine, to just put on the whiteboard, yes, they need vaccines or not. And then the second PDSA cycle, we created new note templates and dot phrases that we can incorporate into existing note templates that people prefer to use in order to kind of remind us to be checking vaccine status and also to document whether we asked or not. So as you see in this example, this patient was delayed on Tdap IPV MMRV. The parent was offered vaccine catch-up, but then they ultimately denied vaccine catch-up at that time. So our two PDSA cycles. So we got our baseline data from July to August. We started our first PDSA cycle in August. This August 7th through 11th week was the first week of the first PDSA cycle, talking about it in huddle, getting the nurses to put it on the whiteboard. And you can see that of the children who came to the walk-in clinic, 49 of them received at least one vaccine. So it doesn't mean that they got fully caught up on vaccination, but they at least received at least one vaccine towards being caught up. And so the percentage of children bounced up from 13% to 41% after that first PDSA cycle. And then during PDSA cycle 2, it was about the same. 42% of children received at least one vaccine that they needed for catch-up. So further discussion. So the vaccine rates did improve. So our goal was to go from 13 to 20%. We did make even better improvement from 13 to 40%. And kind of what exactly contributed to that. So my initial thought was, and I'll talk about this a little bit later too, but was it the flu vaccine? So in August, when we got our baseline data, we weren't really giving too many flu vaccines at that time because it was kind of the end of the previous flu season. And so was the introduction of the new season's flu vaccine contributing to a lot of this bump in vaccination. And I'll show you a chart kind of discussing that later. But then also these kids got at least one vaccine, but doesn't mean they're necessarily caught up. And so that would be something to look at later too. And then what was interesting was, as part of PDSA cycle 1, we wanted to try to get the nurses to put on the whiteboard whether a kid was behind on vaccines or not. And it was just like very difficult from a workflow standpoint, I think, for them to like remember to just look through the chart, which I get because they're already overworked, and to try and ask them to do something else was hard for them. But what was interesting is as we had more kids getting the flu vaccine, it kind of became routine in the walk-in clinic for the nurses to ask parents just verbally, do you want to get your child a flu vaccine today or not? And that actually kind of worked in our favor for this for this QI project, because it triggered us to be like, oh, well, they're getting a flu vaccine. Do they need anything else? And so we would go back through the chart and look and see if they need any other vaccines. So a little bit more discussion about the flu vaccine. So as you can see, so this is like PDSA cycle 1, PDSA cycle 2 is around here, where there was a dip in vaccines towards the end of the cycle that we looked at. And so my thought was, I think flu probably is contributing, but to what percent, I'm not really sure. So that would be a future study to look at. But I don't think it's contributing everything, right? Because in October, like the whole month of October, we had pretty good rates of vaccination catch up in our clinic, whereas the flu vaccine rate was already dropping for the summer. So there must be other vaccines in play to contribute to our overall vaccine status. And then HPV, just because we mentioned it before, actually had a pretty steady increase throughout our QI project. So specifically looking at combo 10 and combo 2, because I mentioned those previously. So the overall goal, so in addition to improving from the baseline data of 13%, we also wanted to improve the overall vaccination percentage by 5% in the clinic. And kind of, if you look at the overall, this is from the whole clinic, so walk-in clinic and well child checks, the vaccine status was pretty stable throughout the year. There was a dip again, kind of in the winter months, but overall was pretty stable. So if you look at like when our project started in August of 23 to December, it was essentially the same for combo 10, so 50% and 50%. And then for combo 2, you could argue maybe that it went up about 6%. So maybe we met our goal from that standpoint. But overall, I would say we probably didn't quite reach the goal of increasing the overall vaccine status by 5%. So some barriers. So we did manual data collection. So we had to go into every patient's chart and manually look at their vaccine status. And you couldn't just look at the current time because kids age and they become eligible for vaccines at different times. And so you have to look at like the timestamp for that specific appointment and not the current timestamp and say like, well, what were the children eligible at that time? So that was just very time consuming and made data collection quite tedious and kind of slow. And then also, again, as I mentioned before, changing the workflow. So changing how residents were documenting vaccine status, asking the nurses to do extra work. It takes a lot of reminding and practice to get a change to actually occur. So some future studies, again, like looking at what specific vaccines are kids getting and which ones are contributing the most to our improved data. And then also we are currently working on a kind of a phase 2 of the project where we're developing like a vaccine contract kind of thing where, because right now we accept everyone with like no matter the vaccine status, they could be completely unvaccinated and we will continue to see them. But trying to change that so that there's a protocol in place and that parents are made aware of like a contract that we have at the 2-week visit and every next well child check, getting reminded of the contract, of this schedule that they have proposed to us, and just making sure that kids are getting the vaccines they need. Because we're kind of going to shift away from being fully accepting of not vaccine hesitant families and getting more strict about like who we allow to be in our clinic from a vaccine standpoint. So as I stated before, most of this data or all of this data came from the American Academy of Pediatrics, specifically the Tennessee chapter, and then also the Healthy People 2023 goals. So I just want to thank Dr. Garcia for mentoring us on this project, and then the staff, the nurses, and the residents in our clinic for incorporating our project into their workflow. And then also TNAP was very helpful for helping generate reports for our clinic. So thank you to them.
So the situation in clinic where you guys started by using a huddle, how did that go?
So we have had a huddle ever since the start of clinic. So it was just adding it towards the end of like the reminders for the day. Hey, everybody, look at the vaccine status for your kids.
Okay.
And see who's behind.
Okay. And you may not have been able to be in clinic often enough to answer the next question, but as that was happening, what was the sense of interest or urgency over time? Did that seem to contribute or help?
It seemed to be a good reminder for people, for sure, to check. And the attendings were really good in clinic about like emphasizing it in huddle, because we do huddle every day of the week, and so things that are discussed like Monday, Tuesday aren't necessarily emphasized later in the week because we're like, oh, we've already talked about it. But I feel like the attendings did a good job of making sure, like even on Friday, they were emphasizing it as much as on Monday. So they played a big role in that as well. And then we actually, so the members of the group were actually picked based on the week of clinic. So as people may or may not know, we are on an X plus Y schedule. So we have 3 weeks of a rotation and then we have a 1 week of clinic. And so that 1 week of clinic, each of us are on a different clinic week. And so we were kind of the champion of our project that week. And we would remind, if the attendings didn't discuss it, we would discuss it on huddle and make sure to bring it up.
All right. Anybody else have any comments or questions?
Just curious why you picked HPV vaccine. There's probably more hesitancy, at least. HPV is one of the vaccines you wanted to measure.
So it was a kind of twofold. So one was it was a goal of the Tennessee Association of or American Academy of Pediatrics. So they wanted to increase the flu and HPV. And those are 2 big ones that again are kind of seen as optional, and we discuss them with families, but they're not necessarily widely accepted. And so that was mainly the reason, was trying to incorporate those into those combinations. Those are the goals that TNAP had set. And so we were just kind of following with that, trying to help improve that goal for them and as well as like in our community.
It's sort of President Kennedy's answer, not because it's easy, but because it's hard.
Yeah.
All right. All right. Getting in my steps. All right, let's see what we got next. How you guys doing out there? Woo!
I want to take a break. Thank you. We're halfway through.
Does anybody need a bio break, or should we move ahead? Right.
Okay.
Yeah, I think so. All right. Looking for our next speaker. Is Dr. Sinha here? Uh-oh. Hopefully it's not a major catastrophe in the NICU.
Let's hope not.
All right,
We
so
can go to the next if they're-
yeah.
If they're here.
Well, let's see. I'll escape out of that one. Leapfrogging a little bit. All right. What did I just do? All right. Christy Ramirez and Kara Robinson, representing children's respiratory therapy and quality and safety.
Click to go through.
Yep, click or you can hit the space bar.
Awesome. Okay. All right. I guess we'll go ahead and get started. Thank you for having us today. I'm Kara Robinson with Quality and Safety, and with me I have Christy Ramirez, who has really spearheaded our UE reduction efforts for Children's Hospital, and she's our pediatric respiratory manager.
So to start off with, we'd just like to give just a brief definition of what UE is provided to us from Solutions for Patient Safety, SPS.
So with SPS, not only do we get a defined measurement for all of our hacks, but we also receive process measures that have been validated by different cohorts. And so the process measures you see on the screen have been validated by, there were about 53 children's hospitals that participated in this particular initiative back in, I believe, 2017 timeframe. So currently the 2 standard bundle elements for UE, which is another thing that we like to call these, are standardized securement methods and reference points, as well as a protocol for high-risk situations. Although the multidisciplinary ACA and active discussion on extubation readiness are not standard elements currently, they are only recommended by the network. We do implement all of these within Children's Hospital because we've seen such great success from using those. So here is a little bit more information in regards to our outcomes measures for UE. So we define by both unit and severity for our numerator, and then our denominator, of course, includes total number of ventilator days, per unit. It does exclude tracheostomy days, which I think is important to note. And here's just an example of how we calculate that for both NICU and PICU, and then as well as our hospital UE rate. We don't have a pediatric CVICU, which is what you see here as CICU, so we will not be measuring that. Here is our Children's Hospital control chart, and we began reporting our data to the network within, I believe it's July 2019 timeframe. So you see that here, and then to January of 2024. You'll note a significant improvement, so a downward trend in our centerline rate for the hospital in April of 2022. We'll talk a little bit more about this in depth in the future, but we had PDSA cycles that were conducted within the NICU setting from January to March of 2022 that we did officially adopt within the NICU in April of 2022. In the future, fast forward, we decided to conduct the same PDSA cycles within the PICU setting the year after. And we'll show you some graphs here in a second that'll help that make sense. So what's the cost and impact of a UE? So it's been attributed to about $36,000 in cost per event. And this is attributed to the various laboratory testing, radiologic studies, personnel needs, as well as medications and things like that following a UE event that can occur. Also, hospital length of stay is significant here in terms of impact because an additional 6.5 days dependent upon how the patient tolerates a UE. So pretty impressive slide. Here's the cost analysis for Children's Hospital. And I just want to draw your attention here because we began reporting in July of 2019. So really this right here is about double what you see. So total on this slide, there's attributed cost of about $4.8 million for NICU, PICU, and Children's Hospital altogether. If you pay close attention to the light blue, you'll see that that is the NICU rate for each year, and then the dark blue is PICU. And you may be wondering why all of a sudden we had a pretty low rate within PICU, but then all of a sudden 2022, it looks like we, more than doubled that rate. And that's because there were initiatives at the time for ICU liberation. So this huge movement in decreasing delirium and long-term effects in sedation within the pediatric ICU setting. And so we had a lot lighter sedation. Patients were extubating actually about an hour before we were about to extubate them. So we had to change some things up during that time frame.
And so this is our UE committee members. And we are looking forward to, in the future, adding both radiology, anesthesia, surgical services to join our team. So we're kind of small right now, but we're looking to grow as we keep going forward with some of these endeavors that we're looking at.
Mm-hmm. We found that standardizing our meeting structure also has really helped us drive improvement efforts. It keeps us on the same page and everyone has the same expectations for every meeting. So we have a lot to bring back to these meetings and really robust discussions. Here's our key driver diagram that we like to work from each month for UE. It's very busy. Most of our key drivers are from our UE bundle that we showed you earlier with our process measures. In addition to that, we have knowledge and engagement of key stakeholders, and then just multidisciplinary care coordination. So our SMART goal here is that we will reduce our hospital centerline by 20% by December of 31st, 2024. We are currently meeting that goal for the network, which we're really excited about. But I want to emphasize that ultimately our goal is zero harm. So as you can see here, we wanted to make sure that our global aim was that we were going to eliminate all UEs from pediatric patients at Children's Hospital. So even though we're doing really well, we still have a little ways to go. Here is a Pareto that shows our main reasons for unplanned extubations. So I believe there's about 133 events total on this Pareto, and the top three being agitation, loose tape holder, and repositioning. So we'll talk a little bit more about that here shortly when we show you some of our PDSA cycles.
Okay, so when we were looking at this to figure out why we were having so many unplanned extubations, we started asking why. Like, why did that happen? And that moved us to the next question. Well, why did that happen? And we ended up just drilling down pretty deep into seeing what the root cause was for having our unplanned extubations. And what we kind of came to the conclusion was respiratory was kind of owning it kind of themselves, and we didn't want that to continue to happen. So we partnered with our NICU leadership, nursing leadership, to come up with a way that we could fix that, and it just be a combined, because you have staffing issues with nurses, you have staffing issues with respiratory therapy. So just combining that and make it more of a team effort was what we were headed for. And so from that, we ended up doing, nurses started doing Q1 hour assessments of their endotracheal tubes. And they would let us know, respiratory, know if it was clean, dry, and intact. And if it wasn't, then they would put that they notified RT. And so then it came back to us then to be the person that needs to take care of that ET tube.
Otherwise known as accountability partner.
Yeah, accountability. Yeah. So in January of 2022, NICU nurses partnered with us. We did the Q1 hour ET tube checks. Yes. And we ended up adopting that then in March of 2022. So moving forward then to PICU, we did see that increase in PICU. And so we started to adopt some of the things that we had used in NICU to try and help us to decrease our unplanned extubations there. So our PICU nurse educator ended up doing some single point lessons for us on our holders to get both nurses and respiratory on board with how that was going to go about. And we also started using tape as a secondary holding device, using the H-tape method with that. And just continuing on with a guideline for securing our ET tubes that we use universally throughout the hospital, well, Children's Hospital.
Here's just an example of the PDSA that was conducted initially in the NICU from January to March 2022. Flipped the script in 2023, like Christy just mentioned earlier. We conducted the same PDSA cycle in the PICU setting at the time, and then adopted both in NICU in 2022 of April of 2022, and then in the PICU, I believe it was May of 2023. Because there was such significant improvement in both areas, we had to adopt those practices. So here is our control chart for the NICU specifically. And again, our interventions that we initially studied were the timeframe right here that you see, January through about March. And so at this point, we saw, goodness, how many months of zero harm. We would have an occasional 1 or 2 events that occurred. But as you can see here from our graph, mostly zero harm. So
we did celebrate in NICU for this, and we went 284 days without an unplanned extubation. So it was quite significant with just showing the improvement that we made in that time. I don't know if we've ever done 284 days.
No, absolutely not.
And so this was the PDSA cycle that we did for PICU as well, using the same interventions that we used in our NICU. Just to note for this, with this cycle, in 2022, PICU had 8 unplanned extubations, and in 2023, they knocked it down to 4. So they cut it in half.
All right, so here's our PICU rate, in which we show zero harm from I believe March timeframe to June of 2023. And then again, we would see the occasional uptick. And I just want to note that we'll talk about it here in the future, but we like to learn from not only the past and the present, and then of course try to be proactive in the future. So anytime we see an uptick in an event or an outcome, we really drill down into the weeds. We get really nitty gritty into what may have contributed so that ultimately we can prevent that in the future as well. So here is our ACA form that we currently use. We actually use this in all settings. So anywhere within Children's Hospital, there is an unplanned extubation. This is the tool that we're going to use. Initially, we began using this kind of retrospectively from our UE committee standpoint. So it would be something that we talk about each month, anytime we'd have an outcome. However, since then, fast forward about a year, we not only review it from our UE committee standpoint, we've really partnered with our frontline staff to utilize this tool, and we call it a learning review, and it's pretty immediate. And so our ultimate goal is within about 30 minutes to an hour following an event within the unit. So we are using multidisciplinary care team members, so our physicians, respiratory nursing staff, to really get into the weeds of what may have contributed to the event in real time, so that we don't forget about those small details that sometimes seem really insignificant, but as we have found from multiple PDSA cycles, a lot of times could be main contributing factors to why we're having UEs. So this is just an example of that form. So what are our key learnings here? Shared accountability is vital. So partnership between our respiratory, nursing staff, radiology, all of our different care team members is so vastly important. We utilize a high-risk protocol, so we call it 2 for tubes here. And we actually have defined jobs. So respiratory therapy owns the endotracheal tube, whereas nursing owns other lines, drains, tubes, and patient safety aspect. It's 2 for tubes, but sometimes you may see 3 to 4 to 5 people. So it could be 5 to tubes, but 2 for tubes just sounded better. So that's our protocol that we like to utilize for that, for any high risk situation. And those are, again, have been stratified by the SPS network, which is really helpful. In terms of leadership engagement, so Gemba walks. We love Gemba walks. We like to walk around and observe our processes in real time. So again, we talked about learning from our outcomes and our past events, but also just going to the bedsides, talking with staff, observing signage. You learn a lot in real time. So it's that work is done versus work is imagined aspect has been extremely helpful. Recently, we began themed senior leader rounds as well. So we walk around with a various hack in mind. And so, for example, for unplanned extubations, we'll talk to staff about challenges, celebrations, how long we've gone without an event, as well as learnings and just asking for their help and their insight. What do they feel like has really driven down our harm in UEs? What could we be doing better? What do we need to do differently? Or what should we be looking at that we're not currently looking at? And we're able to really speed up our progress there by doing so. And then the other thing I'll mention is just that multidisciplinary tool. So again, the more real-time learning reviews that you have, this is for any hack, any sort of harm event or harm-related event, you're going to get more robust data from that than you are from a tool that you use 30 days later. So as much real-time data as you can acquire, the better.
So next step. So where do we go from here? So one of the things that we're looking at right now is our safety disparities. And we're actually really excited about, we're going to be joining teamwork with
Our DEI team.
DEI team, yes, to try and look at that moving forward. So these are just some more of the, extubation readiness. We've still got to talk about that more and what does that mean, and just moving along there. So we still have a lot of work to do, I guess is what
Absolutely.
I'm trying to say.
And for safety disparities, this will be a 2-phased approach just to keep us in line with SPS network. So phase 1 is just data stratification. So we're going to look at 2023 onward and acquiring race and ethnicity data specific to UE. And then phase 2, actually, I believe we get those objectives from the network July of this year. And that will be where we utilize that stratified data to truly improve our outcomes with safety disparities. So we're really excited about that. Some works in progress, so K cards, the Kimishiba cards, to increase our process reliability or our inter-rater reliability. That's also something that we are currently working towards. I believe PICU is going to be our pilot for that because they're currently driving that. Just a huge thank you.
Yes. It takes a team to get this all done, and between NICU, PICU, this is just a small amount of people. It's really all of PICU, all of NICU combined together. And Kathy Thurman,
Absolutely.
she does a wonderful job for us. So,
any questions? No.
Dr. Sinha was caught up in the cruel clinical world we live in. He's trying to see patients this morning. All right. So welcome, Dr. Sinha from the NICU.
All right, thank you very much for the opportunity to speak. Thanks for everybody for being here. Support us. So our project is a multi-phase intervention to decrease the rate of necrotizing enterocolitis in the NICU. We have our team up here, and several of them are here in the crowd today. So what is NEC? It's a very significant problem in the neonatal intensive care. It's a very substantial cost of morbidity and mortality. Some studies quote between 10 and 50% mortality, depending upon where you are, what you look at, and what factors are involved. Each case of surgical NEC will increase costs significantly between $300,000 to $600,000, about average about $450,000 to $500,000 is what we usually see. And the problem is this is a very multifactorial disease, and it's not just like one thing that we know can cause this. It's been shown, however, though, that if you pay attention to attenuating your removable, modifiable risk factors, and then standardizing care, you can actually make a change. It is a little bit challenging, but we did do this. We started out by standardizing our feeding protocol. We then improved our usage of mother's own milk. We improved the rate of optimal cord clamping, and then utilizing a human milk drive fortifier in a more sterile fashion, and refining our sterile practices in the NICU. It was a very large multidisciplinary project. We started it in 2019, and it was a continuation of a project that started in 2010, actually. In December of 2018, we transitioned from a corporate practice to a hospital-based employed academic group, and we were required to come up with models of care per our DNV procedure as opposed to policies within our unit. So we put together a multidisciplinary team of physicians, NNPs, nurses, dietitians, speech therapists, IBCLCs, and through the routine PDSA cycles, came up with a plan to try to make this better. So here's one of the first problems is that when you could talk about a SMART aim, you want to talk about specific, measurable, achievable, relevant, and time-bound. One of the hardest things about NEC is that it's a small percentage. If you look at the graph on the left, you'll see that on average, it's only 6% of our VLBW babies. And to get from 50th percentile to greater than 25th percentile, you're talking going from 6% to 2%. Now we average about 125 cases. So you're talking about 7 cases down to about 4. And that kind of number is with those kinds of numbers, it's very hard to keep track of year over year. So the first thing we needed to do was translate into a month-to-month basis. Dr. Kaplan at Boston Children's published a series that showed you can use number of incidences of stage 2 NEC versus 100 VLBW days. So a VLBW is a infant under 1,500 grams. And based on that, you can get a monthly rate as opposed to a yearly percentage. And so our goal when we looked at our baseline was about 0.103 per 100 VLBW days. And our goal was to get to a 0.03 per 100 VLBW days, which is 2%, essentially our top quartile per the Vermont Oxford Network. And our goal was to do this in about 4 years. This is a fishbone analysis, and I'll be kind of honest, this is a little bit more of a retrospective fishbone analysis. We obviously had put a lot of these ideas to pen and paper, but never really just drew it out this way. But from an academic point of view, this is truly what we would think of when we think of all the things that are necessary for this project to occur. We're going to focus in a lot on these process measures because that really is a big part, but as we see this project move forward, materials, environment, people, and machines are going to become significantly more important. So here's our primary outcome. On the left, you'll see the rate of NEC per 100 VLBW days. And this, let's see if I have a mouse. Do I have a mouse? Yes, I do, right here. So this is our rate, and our baseline rate, you can see, is 0.103%. And you can see the number of interventions that we had, and they're kind of clustered because we'll kind of go through them individually here. But as they were all combined, you can see that our rate has dropped here to 0.037%, which is technically a 66% reduction in NEC and almost brings us to 2% or top quartile. The first three revisions of our project was to look at our feeding guidelines. It's been shown over and over that if you have standard feeding guidelines and you follow them, they will reduce your risk of NEC. So we went back, we actually established our feeding guidelines in June of 2019, and Vicki was so kind as to go back and do a retrospective review and looked at the feeding patterns that we had been utilizing at the beginning of the transition to before the feeding guidelines to say, if we had these guidelines in check, would there be a difference? And the answer is yes. There's a very significant decrease where only about 65% of people are following the feeding guidelines. Implementation of the guidelines, however, only got us to about 85%. And then with steady revisions through several PDSA cycles, where we looked at why people were not being compliant with the feeding guideline, we made adjustments to it. And as you can see, as we've come here towards now November of 22, we're approaching near 100% compliance with our feeding guideline. And we've had two changes, and the lower confidence limit on this, as you can see, is getting considerably smaller, which is a decrease in the variability of how many people are actually following the guideline. Or I should say maybe in the positive, and improvement in the number of people who are following the guideline more closely. How's that? This was another very, very, in my opinion, one of the most important things we did. It's known very well that if you increase maternal milk expression and give that to the babies, that you'll decrease your risk for NEC. We also, in the early part of our this project, we had one very dedicated IBCLC, but was only there during the daytime hours. This increase in IBCLCs went to having 3 IBCLCs covering almost an 18-hour period in the NICU. It's some overlap over multiple days, and including weekends and whatnot, which initially getting that this drop, I think, was because it took a while to get from, we went from 1 to 0 to 3, and I think that's shown here pretty well. But we're starting here at almost 32% maternal milk being used in the unit, now up to 52%. A goal, it's hard to express what a goal for this is. There's one publication out of India that has put it at 80%, which is unbelievable. I think depending upon a number of factors in your unit, this number can be increased to probably 60 to 70%, but requires very significant resources. Optimal cord clamping is the allowing a, well, what's old is new, allowing a baby to maintain connection with mom post-delivery for at least 1 minute has been shown to significantly reduce a number of problems in infants, including mortality, NEC, anemia, and so on and so forth. So TIPQC, which is our Tennessee initiative for perinatal quality collaborative, started looking at this, and we were at about 55–54%. And with Dr. Marcelo Rains's interventions in his program, we were able to increase currently to about 76% optimal cord clamping. The goal is, in my opinion, should be 90%, but it really depends. Like at Erlanger East, we have a very high rate. It's almost near 100%. And it's a much lower risk group of patients. Here, because of the high risk nature, where you can't do optimal cord clamping for things like placental abruption or other such things like that, your numbers will never be 100%. But I think we're trying to take a look at this as an average between the two units. And I think if you averaged out the two units, it would probably be a little bit higher, somewhere around 84%. A couple of other things is that this is to point out that one of the factors for causing NEC or thought to cause NEC is the use of a bovine milk fortifier, so Similac or Infamil, used to increase the calories of maternal milk. And some people can make the argument, well, you didn't get any NEC because none of your group fortifies your patients. And the answer to that is, no, we keep track of that. And do we do it in a timely manner? So once children are about 2/3 of the way on their enteral feeds and 1/3 of the way on their IV feeds, we put extra calories in their milk. And do we do it in a timely fashion? And the answer is yes. One of the things you'll notice here is there's a drop towards December of 21, 22. And you'll see a significant increase in the variability there. Most of that was due to the fact that we switched from bovine milk fortifier to a human milk fortifier. And in doing so, we changed the time when you do that fortification from about 2/3 of the way to 1/3 of the way. And fortifying earlier is one of those cultural changes amongst physicians and practitioners that takes time, because everybody's afraid to put extra calories in the milk because extra calories causes problems. And so we are seeing some kind of increase in variability with that, but we are working to improve that overall. One of the balancing measures is, again, that if you feed your babies very, very slowly, then you won't achieve birth weight by day of life 14, which is a standard indicator of whether or not you're feeding babies properly. And throughout this entire project, you'll see that there was zero variability in zero change and zero variability change in infants who have regained birth weight by day of life 14. They have stayed pretty constantly at 75%, and a unit average is about 80%. So we're not too far off our goal. And the other balancing measure, again, is achieving full feeds. So we define this as about 140 ml per kilo per day of 24-calorie milk, which means we gave the feeds, we fortified them, and removed them from IV fluids. So these infants are reaching a full diet. So someone could make the argument of saying, well, you don't have NEC because you don't ever feed your kids. That can be true, but in this case, it's not. As you can see, we have a fairly steady measure of infants who achieve full feeds throughout the entire 4-year project. So in conclusion, we see a rate decrease from 0.103% to 0.037%, a 66% reduction. We are not completely at our goal, and our balancing measures are stable. The efforts to improve trends in the NICU, I like to point this out. They looked at the Vermont Oxford Network, which is 100,000 babies or more, from 1997 to 2021. So a very long period of time for infant statistics and numbers. And the national rate of necrotizing enterocolitis is stuck. That bar that I showed you earlier, where we were at 50th percentile and 2 to 10%, that has been stuck for at least since 2015 without budging. So nationally, it's a very difficult problem to work with, and we're not exactly sure why. But a multidisciplinary approach is absolutely key into making this work. And it does take a significant amount of time and effort by everyone to improve the numbers. The lessons learned is that you have to define NEC as a rate, not a yearly percentage, in order to make changes monthly versus yearly. It's a rare event, so it can be better visualized over a long period of time with such things as a rate or days between events. Unit-wide participation is absolutely integral. The number of moving parts to feed a child starts at the beginning and ends with almost every single person in the NICU who's working there. So it is incredibly important that everyone be involved. And the limitations are that this was all staff volunteer hours. And it requires a lot of education. These programs that are used to create these graphs and stuff, all the analysis, they're not just Excel spreadsheets. They're QI macros and other such things that are required for us to learn. So it can be pretty difficult. And then, of course, staff turnover is a big portion of what we struggle with. Our next steps, if we look at our cases, we did a retrospective analysis of cases in our unit by who got NEC. And 80% of them are under 1,000 grams, which is currently who gets human milk fortifier versus a bovine milk fortifier. 10% were between 1,001 and 1,250, and 10% between 1,250 and 1,500 grams. So the question is, can we increase the number of infants who do this? The cost for using an all human milk diet in this group, because they're larger in the volume that you're using, almost just increasing by 20% can almost double the amount of cost for this the unit. And it is not cheap. It is a humongous cost in the millions of dollars. So it's a very difficult question to ask. We initially started out at 1,500 grams, but due to costs, we cut it back to 1,000 grams. Can the data collection be automated to some extent? Right now, we can get the actual total milliliters of maternal breast milk expressed in the unit and given to babies as a whole number on a monthly basis now as a report. Vicki was able to set that up with Epic, which was unbelievable. The numbers that we get and we were able to track. The question is, could we track some of this other stuff if we entered in things a little bit differently? And then the next thing that is going to be a fairly substantial investment, which is considered the standard of care for milk preparation in a hospital, is to have your own milk prep room and where you have a milk technician and they prepare 24 hours worth of milk in a sterile fashion in one room and then provide it to the nurse, as opposed to each nurse making their own concentrated milk at the bedside. It takes a village to do this kind of stuff. So I wanted to give a very personal thank you to everyone in here who has made this project successful. And if anybody needs to learn from the Jedi of MSXL, it's Vicki. She has like literally stacks and stacks and stacks of charts of Excel spreadsheets that she has done, which still yet today blow my mind. And has been the backbone of getting this project done. Without her help, we wouldn't have gotten anything done. Thank you for your time. Questions?
Any questions? Big deal, 4 years of effort. What were some of the things that you felt were key to keeping the project flowing over time?
Buy-in from multiple levels. So as medical director, I realized I was the ultimate middleman, making everybody happy from the C-suite to the partners and the staff. And getting that buy-in, not only from the people who are actually doing that work, but the support from the C-suite to put in the time, money, and effort that it takes to move this needle was absolutely key. And Dr. Woods really was incredibly supportive of all of this.
Here we go. I got you.
Some of you may want to know, but we had about 759 babies in this entire project
yeah,
over the
that's right.
course of 5 years. And our nutrition subcommittee was a big part of keeping that going. Everyone multidisciplinary, meeting monthly over the course of that 5-year period to discuss problems and to discuss where we go from here and to look at the data, everyone to look at it and see how we can improve.
Any other questions or comments? Okay. All right. Well, thank you.
Six, gotcha.
All right. And our final presentation this morning is it Brittany White? Yes. All right, Brittany White representing pharmacy.
Good morning, everyone. I'm Brittany White. I'm here representing the pharmacy department. And I'm going to be talking to you guys about an enormous project that we've been working on through multiple PDSA cycles since 2019. For a little bit of background, I think everybody knows that heparin infusions are one of the first-line anticoagulant options for hospitalized patients with acute thrombotic disease. And this is a high-risk medication. And it's become a national focus of hospital safety initiatives because of documentation of frequent medication errors. So whether your organization is credentialed by the Joint Commission or by the DNV, what we see is that across the nation, these organizations are implementing requirements for monitoring and process improvement for high-risk medications, specifically with heparin infusions. The literature has also shown that one of the most important things about heparin infusions is achieving therapeutic levels or goal levels. We measure these as APTT levels to do that quickly. So doing this within the first 24 hours of therapy helps reduce compromising patient care. It reduces the risk that patients will develop recurrent thrombotic disease by up to 15 times. There has been very minimal literature, though, showing how we can improve achieving these goals. There is some small literature that indicates that pharmacist involvement in heparin dosing can be associated with improving the achievement of these therapeutic outcomes. So what is the current problem at our facility? We conducted a series of heparin infusion protocol evaluations between 2019 and up until the current PDSA cycle. Because of system-wide reports of drug errors. So we were not alone. We are experiencing the same problems with this medication as other hospitals across the nation. But we identified 3 primary safety concerns at our hospital. The first of these was that we had evidence of heparin protocol noncompliance. And for a little bit of background, our hospital has historically used a nurse-managed heparin protocol. So the provider orders a heparin drip, the pharmacy verifies that order and sends it to the floor. And from then on out, it is one bedside nurse working with receiving lab results, checking the dose, making sure that the dose is effective and it's administered in a safe way. We also saw delays in heparin infusion dose titrations in response to those APTT results. The goal being that these titrations occur in less than an hour after a lab results because this is a high-risk medication. And we also noticed that we did not have a way to document heparin verbal orders. So for example, when a patient needs to go from a floor or a unit area to a procedural area, it is very commonplace for those orders to be given verbally by the provider. And so we did not have a way to track these orders. And so that was a potential gap we saw in being compliant for DNV requirements. So if you look at the graph on the left, this is just 2 bars really to point out what the struggle has been and how long this has been going on. So you can see here on the left, back in 1999, when heparin drips were kind of a mix of being managed or dosed by physicians, and then also some nurse-driven protocols, reported protocol compliance rates were less than 50%, the goal being 100%. Then in 2017, another wide study was done looking at primarily nurse-managed protocols. And you could see an enormous increase in protocol compliance rates, although you'll note that we're not really looking at any safety outcomes here. Just are we able to follow these protocols that we set out? So in 2021, after we'd noted multiple safety reports, we took our own evaluation of our own protocol compliance and divided that into 4 domains. So you can see that the percentage of time or the percentage of patient charts that we reviewed in which the initial heparin infusion rate was selected correctly was about 95%, which is great. But then when you look at whether an initial heparin bolus dose was given as ordered by the physician, this was only 80% of the time. And as I previously mentioned, achieving therapeutic APTT levels in the first 24 hours is one of the most important parts of managing this drug safely. We also saw only 22% of as-needed heparin bolus doses that were ordered by the physician for response to subtherapeutic lab values were given in the population of patients observed. And then finally, only 60% of heparin dose changes were occurring at the pump within an hour of that PTT result. So the delays in care are there. So we had 4 big aims, and this was a lot for our department. Our biggest one was to improve rates of heparin protocol dose compliance. How are we going to do this? This is a national problem. We have limited human resources. We wanted to achieve time from lab result to the heparin dose change less than 60 minutes to just basically our goal was to increase in any capacity, increase what we had seen on a prior evaluation. We also wanted to achieve DMV compliance with having a way to document heparin hold orders on the MAR. Again, this doesn't exist. There's no really great description of how to accomplish this. And then we wanted to engage nurses and providers in team-based heparin communication. I think the theme of today's presentations is certainly the importance of multidisciplinary involvement. And so that's why, one of the reasons why this project was such a huge undertaking, because although it's presented by the pharmacy department, this really involves everyone on our teams. So in looking at a cause analysis, in terms of methods, where are the process breakdowns? It was very clear that heparin's order set language is unclear based on some of the e-safes that we reviewed. And that sometimes protocols didn't really support team communication in terms of ordering a heparin drip. And then, how do we best notify other team members such as nursing and pharmacy when it needs to be paused or needs to be resumed? From an environment standpoint, we were certainly sure that high patient to nurse ratios were going to be a problem. It's really hard to respond within an hour to a lab result if your patients need you at the bedside. From a system standpoint, we have access to Epic Secure Chat, and that's increasing, I think, across all disciplines, but that wasn't optimized in a way for multiple team members to talk about heparin infusions. We also noticed that there's an IV pump communication barrier. There are many hospitals that have IV smart pumps where when the dose is changed at the pump, that is immediately documented on the MAR and communicated to any team member who looks at the MAR. So right now we don't have that. And from a people standpoint, because of high turnover rates, we know there's always a heparin protocol knowledge deficit and just really a barrier to provider to end user communication. So how would we measure this enormous undertaking? Number one, we wanted to look at the frequency of heparin dosing errors after implementation of a pharmacist-driven heparin order set. So we looked at the rate of correct heparin infusion dose adjustments based on the PTT result as was laid out by the protocol. We also wanted to look at the rate of bolus doses of heparin that were actually administered when they were ordered. In terms of the heparin dose titration delays we saw, we wanted to see the mean time from the PTT result to a nurse action at the IV pump of less than 1 hour. So one of our main concerns was if we pull pharmacists into this workflow, is the end result going to be that we delay the nurses from actually caring for the patient at the bedside by becoming a middleman? And so we looked at the rate of dose titrations made more than 60 minutes after a lab result. We also wanted to implement a new order type for our providers to communicate to nurses and pharmacy when a heparin drip should be paused on the way to a procedural area, for example, or in the case of bleeding. and implementing a new heparin EMR communication tool, which is just a fancy way to say creating an Epic chat group that was accessible to nurses, pharmacists, and physicians 24 hours a day. So for our first PDSA cycle, we really were just uncovering facts. What are the problems? We wanted to just optimize the use of our heparin infusion protocols. And so we kind of conducted our fishbone diagram and we conducted a literature review to say, okay, if this is such a widely reported problem, what can be done about it? So that's when we first conducted our first heparin protocol use evaluation across the system. And this did exclude pediatric patients, but it did include surgical patients and non-surgical patients on the adult side. And what we found, and I laugh because this is cited across multiple specialties, is that we had a really poor time in therapeutic range for our PTTs at 42%. The time it took to get to a therapeutic level, though, was 8 hours. And that we were pretty impressed by because the goal is just less than 24 hours. So just for a little bit of context, we check PTTs every 6 hours. So this was collected by the first time that the lab resulted after the drip was started. But we did see a 30% rate of protocol noncompliance. So what did we do? First things first, we did education and released an EOL to all nurse and pharmacy staff. In 2021, we repeated this cycle. We assessed for a change in the mean time in therapeutic range and any mean time to our first target APTT level. So again, we conducted this study looking solely at lab parameters. Out of 800 PTT results that we looked at, we saw that our time in therapeutic range had actually decreased to 33%. And our time to therapeutic goals had actually increased to 15 hours. And so sadly, there was no improvement from cycle 1. So we decided to revise one of our heparin protocol starting doses to see if we could sort of mirror protocols from other facilities that were a little less conservative. Would we achieve a therapeutic goal more quickly? We really didn't plan to conduct a third PDSA cycle, but this brings us to our current cycle in which we have implemented a pharmacist dose heparin protocol. Before we implemented this, we observed 53 eSafe reports from our historic protocol over a 5-month period. So we completely rehashed our plan and decided to implement a really novel pharmacist heparin dosing protocol that has not yet been described in the literature in the way that we approached it. We called together an interprofessional work group comprised of nursing staff, Epic Orders team members, physicians, pharmacists, and we designed this unique pharmacist dosed heparin consult, and we retired our nurse-driven protocol. This included building an entirely new Epic order that would allow a provider to specify the time and date and any specific directions of when they wanted to hold a heparin drip and also when they wanted to restart it. And this is really important because that was visible not only to other physicians on the team who may be interested in heparin plans, but not the attending service and may not necessarily be involved in those conversations with the nurse. It also allowed nursing and pharmacy to see on the MAR what those future plans were. And then we also started a secure chat group called Heparin Pharmacist Communication Group, which is available 24 hours a day for all team members. And so now this brings us to our analysis of this protocol. We chose to look at compliance and that time from the PTT result to the dose adjustment. And then of course, we're still looking at reported safety events. And looking at our results, you can see that this chart is depicting % protocol compliance. And the light blue bar is our historic nurse-driven heparin protocol. So those results are what we previously discussed. In the dark blue bar, you can see the pharmacist managed protocol results. And I think it looks a little bit ridiculous that it says they're all 100%. But you have to realize that we went from dual nurse verification to dual nurse verification plus a third-party triple check. And so out of 50 charts that we reviewed for patients on heparin for about an average of 3 days, PTTs every 6 hours for those 3 days, we saw that bolus doses and PRN doses were consistently administered as ordered by the provider. And how did we do with time? We observed in those 50 patients no incidence of rates that took longer than 1 hour to adjust from the time that the PTT resulted. So that's not only including the time that it took for the pharmacist to review the results and change the order on the MAR, but that includes not delaying the time that it takes for the nurse to be able to make the change at the bedside. The median time for a pharmacist to review a lab result and order a dose change was 7 minutes. And that was really important to us because, again, we want to make sure that we're not delaying our nursing colleagues. And the median time from that PTT result to action at the pump was 20 minutes. So this reduced also our mean time to first therapeutic APTT to 7 hours. And so for context, that's essentially the first PTT check. This is some screenshots of how we built this and what it looks like for providers. So screenshot number 1 is just what the consult looks like. One thing that I think our providers really enjoyed is that they can select an indication. And we can also, as pharmacy, kind of double check that the correct protocol intensity has been selected. And if something looks off, it allows us a chance to contact the provider via that secure chat group and just double check things. 2 is a photo of our order that communicates planned heparin interruptions. So the provider just searches hold heparin. They can enter their plans for the date and even give specific instructions to the pharmacist. And then finally, visibility of provider hold orders. So I think it was really important to us that the nursing staff could see what the provider had sent in terms of an order. And this is the way it will look to the nurse in terms of in special medication instructions, so everybody on the team can see. And this is our chat group. I just want to point out here that this is very widely used. We get multiple messages per day, and sometimes it's simple things like nursing and pharmacy communication just to double check. So in this situation, the nurse says, hey, the baseline PTT is 34. Am I good to start it at this rate? And so the pharmacist is able to reply, hey, this is an odd scenario. Let's go ahead and start at this rate because that was the last therapeutic rate. So this prevented a situation where the patient would have been inappropriately started on a high rate, starting over from the protocol all over. And in terms of safety event report monitoring, I don't think it's necessarily comparing apples to apples to assess safety events that were reported in only a 2-month time period. But I'm showing you this here just because this project was actually implemented in December. So these are just some of the safety events that we've collected during that time. Some of these are things we can't control. The order was placed, for example, but 5 times the incorrect rate was actually programmed on the pump. That's something we're going to have to look into. How do we fix that? 3 times, although we have this hold and restart heparin order, we observed that the heparin was stopped at the pump without an order actually being placed. That's something that just comes with education, I think. So those are just some things that we're continuing to monitor. So finally, what did we do? So far, one result that we've come up with based on these findings is to streamline our cardiac cath heparin order sets. This is one of the most common reasons that heparin infusions are stopped or changed when patients are flowing between the floor and the cath lab unit. And so now all team members, including physicians, nurses, pharmacists, have a better idea of exactly what the plan is for the heparin infusion around the time of procedure. So interdisciplinary collaboration to enhance medication use pathways definitely reduces dosing errors and delays in medication use. But a prolonged pharmacist training period over almost 6 months was needed to establish a foundation for this successful project. So this was very time and labor intensive with limited resources. The primary drivers of safety and efficacy, though, were improved. So we did see a shortening of our time to therapeutic APTT, probably because of that triple check I mentioned and focused 24-hour monitoring of pharmacists for lab results. Delays in those dose titrations were decreased because of that 24-hour service. And we have a communication tool now that has really involved all crucial healthcare team members in talking about this high-risk medication. So in conclusion, a pharmacist heparin infusion management service enhanced patient safety through collaborative team care. We did this without actually adding an extra FTE, although increased hours were needed in terms of our initial go live. Pharmacist dosed heparin protocols can speed heparin infusion rate adjustments. And a heparin communication tool that's embedded in the EMR can promote team communication during transitions of care. Some of the limitations included certainly the variability of heparin pharmacokinetics, assessing things like the APTT time and therapeutic range. is really has questionable reliability because of the frequent starts and stops, and really because of the simple fact that everybody who receives heparin metabolizes it differently. But also the lack of IV pump communication with the MAR. So it really made it necessary to rely on accurate charting of when the nurse documented that the heparin dose was given in terms of assessing protocol compliance and times. In the future, we'd like to address some of these limitations by procuring bidirectional smart IV pumps so that we can enhance real-time communication in the MAR. And then also to send out some surveys to our providers and to our nurse colleagues to assess satisfaction with the protocol changes and make sure that the end users perceive this as an overall improvement. I'd like to acknowledge the following groups and individuals for their contributions, and really to acknowledge the entire pharmacy department who has been very, very patient in learning a new skill and really kind of pushing the boundaries of scope of practice to something that's not really yet been documented. So I thank you, and I'll take any questions that you may have.
This was really good. Obviously, it impacted cardiology in a really positive way. So I think it was really fantastic. I'll tell you that from the provider standpoint, it was really beneficial changes that were made.
Why do you think in 2019, when you showed the data of the 50 patients, that there was only like 22% of the PRN doses being given appropriately? Was that some of the doses were not given, or that the doses given were inappropriate as to what the order was?
Sure. Yeah. So there is definitely, I would say, depending on whether you're a nurse or a pharmacist, giving an as-needed bolus dose can be a really subjectively concerning thing. So if you're a MICU nurse and your patient is critically ill or unstable. A lot of judgment calls were made after talking to some of our nursing staff about, well, I just really didn't feel like in this situation, this patient was very ill and that concerned me. Sometimes that was run by the provider who have said, of course, I trust your judgment. So some of it just wasn't given at all. When we looked at administration of them, that 22% there was never a case in which it was felt a bolus dose was given that was inappropriate. Rather, they were ordered, and sometimes it was intentional that a clinical judgment call was made that I did not feel that was appropriate, but also sometimes they were just missed. And so frequently we would see by the time the PTT result was able to be reviewed by the nurse, so much time had passed that we no longer were sure if that PRN dose is appropriate anymore. So what the Secure Chat group has done, and I think one reason we see these being given is one, there's a team-based discussion. Hey, I don't feel comfortable. There's a next, sort of clinical perspective of talking it through. But also when we have subtherapeutic PTT levels, instead of those heparin orders just being in an as-needed section that are not prompted to the nurse, the pharmacists are ordering a once heparin bolus dose order that prompts the nurse, this medication is due right now, in addition to the rate increase at the pump. And so I think catching the attention of helps us realize, oh, this isn't just kind of down in my PRN med section where I'm not going to be prompted. So there's that kind of next step, that prompt.
Any other comments or questions?
When you're doing your APTTs, is there someone in your criteria that you've worked with that looks for the lab's values at a certain time? Or when there's like a delay in the lab actually populating those, is there somebody that catches that within a certain time?
Yeah, so we built a lab inbox for all pharmacy staff that is visible anytime a PTT result populates. There is an immediate flag to the pharmacist lab result inbox, and that's monitored 24 hours a day. We also have a second check in terms of we have a list that's dynamic that shows all patients in the hospital who are receiving a heparin infusion, and there's a handoff that's given. So the pharmacists that are responsible for heparin management during a given shift have a triaged time when the labs are due. And so if that lab has not resulted at the time that it's due, a lot of our epic chats to nursing are, hey, what's going on at bedside? Do you need some help getting that lab drawn? We're delayed now. Yeah. Dr. Mannion? Sure.
It just seems like we have a lot of new nurses in comparison to what we had, I'm dating myself, but 20 years ago plus, in that, we saw nurses at the bedside that were the same nurse for 20 plus years at that time. And so now most of the nurses are brand new. And so it seems like this is a really good process that could be applied probably, in a lot of different institutions, because I'm sure they're also dealing with, new nursing and, is this appropriate for the patient based on the clinical thing? So I think it's good to do this and maybe expand on it a little bit. So
yeah,
thank you for taking the charge on that.
thank you.
All right. Well, what'd y'all think? Awesome. Yeah. Our judges really have a tough job ahead, don't they? I think what I saw was a pretty interesting range of scopes of projects, from scale to a clinic setting with a fairly focused goal and set of interventions, to fairly large scale projects that involved many different units and or specialists participating together. It made me think about some of the overlay between high reliability concepts and what we're trying to achieve. For example, with teaming, several of our speakers commented about the importance of interdisciplinary participation. And one of the things about teaming is how it creates environments that are safe for people to speak up and to share their know-how, their experiences, and it helps to shape ideas in better ways. One of the things that high reliability brings to the table is this notion of deference to expertise. And it doesn't mean deference to title. That's a pretty powerful thing to internalize, because sometimes the best answers and solutions aren't going to come from the person who's calling themselves the leader of the project. In fact, most of the time that's the case. So that's a really powerful concept that was demonstrated, I think, in a number of projects today, and I really, really am impressed by that feature. The other thing is sensitivity to operations. The reality is that in creating solutions, sometimes we create demands or works of people that may not be well positioned to take that on. And there have been several of today's report outs that described some of those as barriers and challenges. So that's kind of a normal feature. The other, of course, time is always a limit. We've seen projects that struggled with the manual aspect of some of the work, getting the data, or reaching out, trying to contact people, and some of the creative thinking that goes into getting past that barrier, whether that be automating some things or perhaps simplifying how you're looking at the process or the outcome. Those are all really interesting concepts that emerged, I think, this morning. Did anyone else have any general comments about some of what they saw? Well, again, I just want to applaud all of our participants today. That was really a great morning. Well, we're at a stage where we're a little bit early in our overall schedule, which is not a bad thing. People get a little bit more free time. Our judges panel will get a chance to get together, start talking about what they saw, do the difficult work of trying to select the best of the presentations this morning, but also create some feedback for the presenters regarding their projects, and hopefully make this a positive experience for everybody who was here. Our schedule has us reconvening at 11:15, which gives us a decent amount of time to either go set up posters if you would like, maybe get an additional snack from our hallway food selection, attend to some other business. Those of you who are involved in program leadership, I know you're looking forward to the announcement midday about program matching today. So best wishes to all of our programs on matching completely today and avoiding the rough and tumble world of getting the secondary match flowing. And I don't think there's anything else I have to announce. Tammy, is there anything else? Okay, so we're not until then? Okay, so everyone, just go ahead and enjoy a portion of your morning. We'll see you back here at 11:15 to hear from our judges and take some pictures together as teams. And Dr. Haynes, you had anything to add?
Just
All
keep
right,
coming.
come on up.
Thanks, Jeff. Sorry. Well, I want to thank everybody for attending, number one. Number two, I do think based on my review of the projects, these were probably the strongest I've seen overall in a number of years, which I think attests to both Dr. Bennett and Dr. Campbell's input over the years of helping us do these projects and learn the methodology to improve the quality of care we deliver. The other thing I would say, it's my goal here to link resident and faculty quality projects to the primary key performance indicators of the hospital. Because I think the hospital in general has not leveraged the academic infrastructure over the years as it should. And we should all contribute to helping our hospital be a place of better care, safer care, and teaching people how to do that. So when they go out of here, even if they don't stay with us, they go to other hospitals and make them better as well. So I think there's a chain or a cascade of quality that we can develop and we should develop. And I appreciate both Dr. Campbell, Dr. Bennett, wherever Jeff is there, he is, he's hiding from me. But and then also all the work that goes into to developing these projects and putting on this day. The other thing, if you notice, there's a lot of IT sort of automated things that go into this. And so there are people not in this room that probably helped the pharmacists, nurses, doctors do these projects. And all they do is sit and finger things all day and create mechanisms within Epic to improve care. So my hat's off to them and Dave Garrett and his team and all the chief medical informatics officers as well, who I'm sure had an input into these. So with that said, 11:15.
Yep.
All right.
Yep.
See you, gang.
All right, friends. I appreciate everybody swinging back by and continuing this program with us. This is kind of the, I guess, the highlight of the morning in the sense of we get to reflect on some of the things we saw and award a best of show type thing. But I think also, for me, the highlight is just seeing how the learnings unfold and see how people, get into the weeds together and identify solutions to challenges that have honestly, in many cases, gone on for years and years and years and years. And just by reframing that, by focusing on data, by sharing our own creative ideas and partnering together strongly, amazing things happen. So that was definitely one of the big points of my morning. So we've got about a half hour till we formally start our poster session out in the medical mall. So I just want to remind everybody to meander through there. There's a lot more work to see up there, about 13 more projects to look through and folks to talk with. So much more to see, much more to do, much more to appreciate. Now I'm going to have my partner in crime, Dr. Campbell, return to the microphone here and proceed with our unveiling.
All right. Ooh, unveiling. Very nice. Well, first of all, I want to echo Dr. Bennett's sentiments. Collectively, I think this was the best collection of projects that we've seen in quite a while. That's just indicative of the work that goes into this, the identification of where we need to improve and putting the teams together to do so. A few things that really popped out to us. I know Dr. Bennett gave us a few words before we broke. Really, to add to that is really the use of data, both baseline data, collaborative data, and data that comes from the project. I thought was very important, and also the collaborative nature. All the projects really crossed over into several domains, I think, which was very encouraging, and the use of national collaboratives, how we're linking in nationally, comparing ourselves nationally is very important as well. And then there was the link to accreditation and things that we do on a regulatory basis that is there as well. So great work, well done by all the teams. With that said, I would like to again thank the three judges who made a very hard decision. Melissa, Christina, and Amelia, if you want to come forward, we can, I don't want to stand up here alone. No, but they did a great job of really looking at the projects. Some of the criteria we used was really basing it on the use of QI methodology, the use of data, and really how it affected our patients and really addressed high-risk areas in the system. So without further ado, we'll announce the winner of Journey to Zero Harm, Reducing Unplanned Extubations in Pediatric Patients, Christy Ramirez and Kara Robinson. There you go, come forward. You don't get out of it that easy just because you're on. You don't think it, no. But I will say it was, because of the quality of the projects, it was close. And I would say there was a 5-way tie for second, but it was a very close scoring. And we want to thank Christy and Kara for the hard work that they put in and all the teams that are involved. So thank you. Yes.
Thank you. We're super excited. This is a project that we have been working on unofficially since about 2017 timeframe. So getting to partner with SBS has been huge for us. And that journey began back in 2019 for us for unplanned extubation. So we'll continue our work, and thank you so much. We were excited to share all of our accomplishments.
All right. Well, I wanted to thank our judges also by offering them a little token. Just a little bit of UT swag to take out of here with you. There you go.
All the perks and benefits.
Absolutely. And you said you wanted some too. So.
Oh, gosh.
Yeah,
You're
there
more
you
than kind,
go.
sir.
There you go. All right.
So my last words are thank you to Tammy. Thank you to Dr. Schwartzberg. Thank you to Dean Haynes. Thank you to Dr. Bennett and everybody that helped put this on, getting the posters going. John, thank you as always as a team effort. I thank everybody.
Okay. In the spirit of continuous improvement, also just request for people's feedback. We do use it. We'll be getting together again in a couple of weeks to review what we learned as a planning team this year and set out to plan a better event next year. So your input will help us do that. We appreciate you. And if there's anybody who wants to come up and do a little bit of a photo op or kind of do a kind of a quick gathering of your buddies, please do come on up here and we'll take some pictures for keepsakes. And thank you again for attending our live platform presentations this morning. Don't miss the posters up in the medical mall.
Mm-hmm. It'll go black so that it won't show up on the, I think that's what John said.
Control B.
That's what he just, yeah, that's what he told me. Oh, there you go.
It just took a second.
Yeah.
Okay.
Just for the picture.
All right. Sure.
Yeah, right. I'm laying over here on the side. No way.
Where's your hat?
Yes.
Oh, where's my hat? I don't know. Where's your hat?
He doesn't want to put it.
He's like, yeah, whatever.
Chef's hat.
Yeah,
Chef's hat.
Chef's hat.
It's good to like that, like. Awesome. Thank you.
Do y'all want to get?
Come on, champs.
Okay.
Front and center.
Look at us. All right.
There we go.
Sorry.
Respiratory therapy rules the world.
Okay, my turn. Don't move.
Uh-oh.
I need TMV pictures.
I can only suck it in so long, so hurry.
Come on.